Hello guys. Good evening. I'm just checking my audio. Can everyone hear me? Okay. So our topic for today would be gastrointestinal system. Yes, good evening. I'm expecting I think 50 plus students. So for tonight, as we go along our lecture, I'd like you to answer through our chat box if I have any questions. So we will be dividing this lecture into three parts: our upper GI system, our lower GI system, and our accessory organs. So before we begin, can I ask everyone, have you eaten your dinner? Kumain na ba lahat ng dinner? Bago tayo mag-start? Yes. Okay. So, good job. So, for today, okay, what we will be talking about would be the anatomy and of course the physiology as well as the common disorders regarding your NCLEX in terms of your gastrointestinal. So, before we begin, alright, let's have a review first of your anatomy, okay, ng ating upper GI muna. So when I say upper GI, okay, that's the first part of your digestion. Question, saan una nagsisimula? Okay, ang ating digestion. Which part of our body, okay, or our GI starts ng ating digestion? Very good. Our oral cavity or our mouth. Okay, and then we will be talking also about the esophagus, the stomach, up until the first part of our small intestine, which is our duodenum. Yes, ma'am, it's still part of our GI tract, mouth until duodenum. So let's begin first with the mouth. Can you give me example of your favorite food? Ano yung kinain natin ngayon, today? Or what's your favorite food, guys? Sinong mahilig sa samgyup? Pasta, si Ma'am Ruby, takoyaki. Wow, ang sarap. SNR pizza. Social mo, Sir CJ, SNR. Ako, lang, Greenwich lang. Alright, so, for example, we ate those kind of foods, our takoyaki, our pizza, our tahong, our pasta, okay? And then, all right, in our mouth, remember, okay, two things happened there. How many? Two, okay? We have one, mechanical digestion. Second, we have chemical digestion. In terms of mechanical digestion, yung kinain nating dinner, say for example, pizza, all right? With our mechanical digestion, this is where mastication happens. Pag sinabing mastication, what do we mean by that one? Masticate. We chew our food. Very good. But my question is, okay, I'm not sure if you're done with your neuro, okay? Can I ask what cranial nerve number is responsible for that chewing or for that mastication of food that we ate? Cranial nerve number 5. And we call that nerve, all right, trigeminal nerve. So for you to remember, okay, trigeminal nerve is responsible for the masticating or for the chewing of food. So para maalala nyo, just remember trigeminal nerve. Okay, that would be our cranial nerve number 5, happening as the mechanical digestion in our mouth. Second, okay, aside from mastication, aside from chewing, okay, meron din tayong chemical digestion. Okay, pag sinabing chemical digestion, there are enzymes present. Okay, and that is in the form of salivary amylase. Okay, that's what we call our thiolin. Okay, ang thiolin, okay, it's a form of amylase that are found in our saliva that help us digest starch, okay, into sugar, all right, and then into bolus. Okay, so kino-convert niya yung starch sa food natin, all right? And when we say bolus, ano yung ibig sabihin ng bolus? Ano na to? Ito na ba yung chewed food? Yes or no? Yes or no? Yes. Okay. Tapos yung bolus, dadaan na siya sa passageway. Where is the passageway of our bolus? That's our What? That would be our, I want everyone to answer. The passageway of our bolus, passageway, dadaan muna siya syempre sa ating esophagus. So aside from being the passageway, all right, I want you to remember this very important part of our esophagus, and that would be our lower esophageal sphincter. When we say lower esophageal sphincter, this is also called as cardiac sphincter, all right? And the main purpose of that one is to prevent backflow of the bolus. Bakit kailangan i-prevent ang backflow ng bolus, guys? Anong pwedeng mangyari pag nagba-backflow yung pagkain na sinuchew at ninunguya natin at nilulunok? What happens? Alright? There will be regurgitation or what we call our what? Commonly termed as reflux or heartburn. Has anyone experienced having heartburn or GERD? Reflux. Sinong naka-experience na neto? Si Ma'am Jo Marie. Ma'am, anong nangyari? Anong ginawa mo? Ba't ka nagkaka-reflux? Is it hereditary or sa lifestyle mo? What did you do? Lifestyle. Coffee is life. Oo nga, lahat tayo favorite natin coffee. And coffee is what? Is it a risk factor? Yes or no? Yes, of course. Now, in our LES, okay, kapag hindi niya ginagampanan yung work niya, or if there's any problem concerning our lower esophageal sphincter, there would be possibility of backflow, and we call that one GERD. Okay, so disorders that we will talking about would be GERD, and hyetalournia is one of the predisposing factor of our GERD. All right. Next, let's move on with our stomach. Okay, our stomach is a very important organ or one of our major organs because it has many function. Number one function of your stomach is digestion of our food. All right, digestion of our food. Okay. And of course, with the help of our hydrochloric acid, okay, produced by what cells? Can you guess? It starts with the letter P. Anong cells ang nagpo-produce or nagtitrigger with the production of our HCl? Very good. That would be our parietal cells. All right? Stomach produces parietal cells, okay? And parietal cells are being triggered to produce hydrochloric acid for digestion. Now, once the bolus are being digested, it will now turn into chyme. Pag sinabing chyme, all right, these are partly solid, partly fluid digested food, all right? Second, function of your stomach is storage, all right? So how long will the food be stored inside our stomach? It will be roughly 30 minutes to an hour, all right? So dapat hindi tayo mabilis kumakain. Dapat slowly lang ang pag-chew ng food natin. Okay? Para hindi tayo agad sumasakit yung tiyan or nabubusog agad. Alright? So, usually 30 minutes to an hour nandun yung food. Okay? Dun din na-digest ng ating stomach. And another very important function of your stomach is for the production ng ating intrinsic factor. Can you remember what is intrinsic factor? Para saan yung intrinsic factor, guys? Or what do you remember about intrinsic factor? Okay, very good. Our parietal cells produce intrinsic factor that are needed, okay, for the absorption ng ating vitamin B12. Vitamin B12, all right? So kapag meron tayong vitamin B12, ano yung tinutulungan niyang blood cells in order for it to mature and develop? Anong blood cells to? Vitamin B12, okay, helps with the maturation and growth and development ng ating red blood cells. Good job. So if there's no intrinsic factor, there's no absorption of vitamin B12, all right? Pwede ba tayo magka-anemia? Specific kind of anemia? Yes or no? And what do you call that anemia? Very good. That would be pernicious anemia. So we will discuss that in details later on. All right. Next organ would be your duodenum, which is the first part of your small intestine. Small intestine are needed for nutrient absorption. However, in your duodenum, there's one very important part, which is your pyloric sphincter. Okay, that's the one connecting your stomach to your duodenum, and it opens and relaxes usually 2 to 4 hours after eating. So after natin kumain ng food, magsusstore siya sa stomach ng 30 minutes to 1 hour. So within 2 to 4 hours, nasa duodenum na siya. Why is pyloric sphincter very important? Can you tell me why? Is it also the same with your lower esophageal sphincter? Yes or no? Does it have the same purpose with your lower esophageal sphincter? Yes, it also prevents backflow. Sphincter, okay, opens, constricts, and relaxes, okay, upon food is been taken down. But if there's problem with your pyloric sphincter, okay, ano naman yung pwedeng mangyari? Okay? This one helps us prevent what? Pwede din magka-GERD, yes, but that would be totally impossible kasi tapos na siya sa stomach, okay? Pag wala tayong stomach, anong pwedeng complication that might arise if it reaches the duodenum right away? That would be our dumping syndrome. Very good. All right. So we will discuss that complication later on as well. But with specific to your stomach and duodenum, we have this kind of disorder, our peptic ulcer disease. Okay, when we say peptic ulcer disease, this is an umbrella of your gastric ulcer and your duodenal ulcer. So we would be able to tackle the difference between your gastric ulcer and your duodenal ulcer. All right, so let's start off first. Okay, this is just nice to know. No need to copy this one. Okay, let's just start off first. Very important, yung mechanism ng ating hydrochloric acid. Since pinag-uusapan naman natin ng digestion, let's discuss about the mechanism of our hydrochloric acid. Question, what organ is involved, all right, with the release of your hydrochloric acid? Anong organ ulit yon ang nagpo-produce or nagtitrigger with the ng release ng ating HCl? What organ produces HCl? Very good. That would be our stomach. And in our stomach, okay, we have what cells again? Anong tandaan nating cells sa stomach? Very good. That would be our parietal cell. So I encourage every one of you to answer in the chat box. So I would know para kung ano kayo, nakakasunod kayo. Alright? So, again, mechanism of your HCl. One thing that triggers our parietal cells, okay, to produce hydrochloric acid, okay, coming from our stomach, okay, remember, one thing that triggers our parietal cells to produce hydrochloric acid coming from your stomach, okay, is what we call our H2 receptors, okay? Ma'am, ano yung H2 receptors, okay? So whenever we say receptors, just remember, it has to bind with something, all right? Our histamine 2 receptors needs to bind with what we call our histamine, okay? So it could activate our parietal cells from our stomach to produce hydrochloric acid. Can I repeat that one? Okay. One thing that triggers our parietal cells to produce hydrochloric acid is what we call our H2 receptors or histamine 2 receptors. So pag sinabing receptors, magbabind yan, okay, with our histamine. Pag nagbind na yan sa histamine, it will now trigger the parietal cells to produce hydrochloric acid. All right, so that's one factor. All right. Next, we also have what we call proton pumps. These are example of our proton pumps. Okay, it also helps triggering our parietal cells to produce hydrochloric acid. Now, ma'am, is hydrochloric acid needed by our stomach? Yes or no? Kailangan ba natin ng hydrochloric acid? Is it normal? Yes, okay. But question, okay? Kapag sobra naman, if there's too much or overproduction of hydrochloric acid, is that a problem? Yes or no? Would that be a problem if there's too much production of our HCl? And HCl, mind you, is very acidic, right? Could the acidity or too much acidity cause an injury to the lining ng ating stomach? Yes or no? Yes, of course. All right. So when it cause injury to the mucosal lining, okay, sa ating epithelial cells ng stomach, all right, pwede bang magkaroon ng inflammation? Yes, all right. So if there's an inflammation, okay, due to the acidity ng ating protective barrier, pwede bang mag-cause ng wound or ulceration? Yes, okay. And that would be what we call our peptic ulcer disease. Okay? So, pwede siyang magkaroon ng injury sa stomach, sa gastric, pwede din sa duodenal. Alright? In any part of your GI organs. Alright? Most specifically, your stomach and your duodenum. So, paano natin mapipigilan yung pag-produce, alright, or pagkakaroon ng ulceration or wound? How do we prevent it? How do we prevent ulcer? Okay. Number one, of course, we avoid the risk factors. All right. We do medications, okay, to prevent ulceration, and we must change our lifestyle. Now, with this mechanism, okay, alam natin yung normal na nangyayari, right? So, might as well, we need to prevent the triggers. Ano ba yung two triggers natin? Ano yung two triggers natin na nagkakos ng inflammation? What are your two triggers? Based from this mechanism, we have your what? Based from this image, what are the two triggers of our HCl production? We have your proton pumps and we have your H2 receptors. Good job. Now, for us to prevent the overproduction of our HCl, all right, and to manage our ulceration, we need to have, or we need to block our triggers, which is one, we give H2 receptor blockers. We need to block our H2 receptors. We also can give proton pump inhibitors. All right? Proton pump inhibitors. Now, ma'am, can we neutralize the acidity? Yes, okay, by giving, all right, antacids to buffer, all right, yung level na ating HCl. Now, for the mucosal lining ng stomach natin, para ma-protect natin yung barrier ng ating stomach, all right, we give our cytoprotective agents. So we will be discussing our upper GI medication. Is this part clear? Guys, RNs, are these part clear? Yes. Okay. So let's start off first with our upper GI medications. Okay. So I want you to memorize this one. All right. Since you have already, I think, your handout, or just if wala, look at the screen na lang. All right. I want you to memorize this part. AHPSC, after, with, before, with. Please memorize this one. I'll give you 60 seconds. All right. AHPSC, after, with, before, with. Sige nga, try to close your eyes and memorize this. AHPSC, after, with, before, with. Let me know if you're done. AHPSC, after, with, before, with. Tell me if you're done. Okay, tapos na. Alright? Again, AHPSC, after, with, before, with. Ma'am, para saan tong mga pinamemorize mo sa amin? So, we will be talking about our upper GI meds. Upper GI meds are medications that will be used with our upper GI disorders. Alright? So, we have the following. Ma'am, ano yung A? A stands for antacids. H stands for H2 receptor blockers. Yung P naman natin ng ating PPI or proton pump inhibitors. S would be our sucralfate and C would be our cytotec. Okay, so discuss natin isa-isa. Let's start off first with our antacids. Okay, pag sinabing antacids, alright, ma'am, why do we use or why do we medicate people with ulceration, mga antacids? Ba't tayo nagbibigay ng antacids? Okay, the mechanism of action for our antacid is to neutralize or buffer the acidity of our HCl in our stomach. Again, antacids neutralizes or buffers our HCl acidity. Okay, and the best time to take it, okay, ano yung best time to take it? Yan, AHPSC, ano yung una? After meals natin yan iti-take. Alright. Now, ano yung examples ng ating antacids? We have your aluminum hydroxide or what we call your amphogel. We also have your magnesium hydroxide or our milk of magnesia. And commonly, we have a combination of both. We have your Maalox. Okay? Usually, the doctors give your Maalox because aluminum hydroxide, okay, or your amphogel causes constipation. Okay? So, meron siyang side effect ng constipation. However, in your magnesium hydroxide or your milk of magnesia, okay, ang side effect naman niya, it causes diarrhea. Alright? So, might as well remove that uncomfortable side effects. So, we give your Maalox. Alright? So, but in any case, these three are your antacids or common antacids that neutralizes or buffers our HCl. And it best time to take this after meals. Alright? Let's now move on with the second, okay, GI medication. We have your H2 receptor blockers that blocks our histamine 2 receptors. Okay, and these are our tidins. Are you familiar with these medications? Our tidins. Yan ang ating cimetidine, ranitidine, famotidine, and so on. Alright? Now, what does it do with our body? Okay? It actually decreases the HCl acid production. Okay? Kasi nga, binablock niya yung trigger, so bumababa yung pag-produce ng HCl. Best time to take it, AHPSC after, what's next? Good job. With meals. Alright? So we take it with meals, our tidins. Now we have common side effect. Just remember our VANDA, vomiting, anorexia, nausea, diarrhea, and abdominal cramps. Alright? But there are cases or meron tayong mga adverse effects when we take tidins, which is also, okay, not good. Alright? Especially sa males. Alright? So we have some cases of gynecomastia, long term. We have your impotence, pwedeng mag-decrease ng libido din to. And for your heart, cardiac arrhythmias. Again, these are not side effects. These are adverse effect. Now, males, single males. Okay, gusto ba natin to? Yes or no? Lalaki lang sasagot. Do we want this? Pero may ulcer tayo, for example. Meron tayong nag-acid tayo. Tapos, binigyan tayo ng, medication. Ano na lang pwedeng, natin? Meds. Anong pwedeng bigay sa atin ng doctor? Doc, change meds tayo. Bigyan, ano na lang, PPI na lang. Siyempre, baka mabawas yung pagkalalaki ko, Doc eh. So, we give your proton pump inhibitors. That's our third medication, or your prazoles. Are these familiar to you? Yung mga prazoles natin. Omeprazoles, esomeprazole, pantoprazoles. Yes, okay. It actually has the same action with your H2 receptor blockers. It decreases your HCl acid production as well. However, the difference is, when's the best time to take this one? AHP, SC, after with, what's next? Okay, before meals. All right. So this is taken before meals. Side effect with your PPI is just the same with your Vanda sa ating tidins. Vomiting, anorexia, nausea, diarrhea, and abdominal cramps. All right? Pero parehas naman ginagamit to sa ating um pag ina-acid tayo, alright? Next would be your sucralfate, alright? As one under your cytoprotective agents. When you say sucralfate, okay, it coats the ulceration. Kino-coat niya yung sugat, okay? And this is taken when? After with, what's next? Before meals. All right. Side effect for your sucralfate or your carafate would be your constipation. Okay, that's a common side effect. And lastly, for your Cytotec, have we heard about this drug, Cytotec? Narinig na ba tong drug na to? Yes. Saan to narinig? Or saan to ginagamit? Sa Quiapo daw. Pero wala namang Quiapo sa US. Ayan, 'di ba? Pero ginagamit ba natin 'to or bawal? Siyempre, we do not want that, especially sa mga Catholic, 'di ba? Kahit sabihin mong pro-abortion yung ibang citizen sa US, siyempre tayo medyo, bawal 'to, okay? However, alright, we do not want, we won't be using that one for abortion purposes. In terms of GI, okay, one of the action of this one is it increases the mucosal lining. And this is best taken when? With meals, all right? Since you know that the adverse effect or the effect of your Cytotec might give congenital defects with the baby, and one of this medication is an abortifacient, anong dapat i-check sa patient prior to giving your Cytotec? What must be done or what must be checked first prior? Your LMP or your last menstrual period. We have to check first if the patient, especially sa mga babae, pag pregnant women, we do not give this drug, or else it would cause abortion. All right? So is this part clear? AHPSC, after with, before with. Yeah, yun yung best time to take these medications. Is this part clear? Yes, all right. So let's now, sige, check muna tayo kung talagang ano, without looking at in your notes, all right? Without looking. Best time to take antacids. Without looking in your notes, after meals. How about tidins? Your cimetidins or your H2 receptor with. How about prazoles? Before. What about sucralfate? Before meals. And what about your Cytotec? With meals. What are the side effects of your tidins and prazoles? Side effect. Vanda. Ano yung Vanda? Letter V? Vomiting. A? N? D? And letter A, abdominal cramps. How about your Cytotec? Prior to giving this drug or prescribing this drug, anong dapat i-check natin sa patient? Last menstrual period. Again, these are your upper GI medication that will be used for our upper GI disorder. And let's talk about our first disorder, our GERD. Is GERD sounds familiar to you? Does GERD sounds familiar to you? GERD means your gastroesophageal reflux disease. Pag sinabing gastroesophageal reflux disease, gastro, stomach, esophageal, esophagus, doon nagkakaroon ng reflux kind of disease. Meaning, there are backflow of gastric and duodenal contents in your esophagus. And these contents are corrosive. Okay, fluids because these are acids. Okay, pwede din may bile sometimes, alright? That would irritate your esophageal tissue. Okay, again, we do not want that one. What happens here, okay, the stomach acid, including your foods, frequently flows back from our esophagus. The danger part here is, would it be able to irritate the lining of your esophagus? Yes or no? Yes, okay. So pag may irritation, pwede bang mag-cause ng inflammation? Okay. And with that irritation, is it painful or painless? Pag nagba-backflow, syempre may acid 'yun sa stomach, 'di ba? Tapos alam niyo ba yung feeling ng parang nahirapan kayo huminga, parang gano'n? Puwede bang or sobrang acid nung feeling, okay, in the esophagus? Yes, yun yun, okay. Actually, I've experienced that one before, alright? So that's what we call our heartburn, okay? So parang bino-burn yung heart part natin kasi ang esophagus is near our heart, 'di ba? So there's like burning sensation, okay? So bakit? Alright? Ano bang cause, ma'am? Ba't nagkaka-GERD? Alright? Number one is because commonly incompetent ang ating sphincter. Okay? Hindi niya nagagawa yung purpose niya kaya bumabalik yung food. Alright? So we have an incompetent lower esophageal sphincter. Alright? Because what are the causes? Number one, pwedeng aging. Okay? Usually sa mga matatanda, mas prominent yung GERD, okay, or mas lagi silang ina-acid, okay? It's because number one, aging, okay, as we age, okay, it would weaken our sphincter, alright? Nagwi-weaken yung sphincter natin. Number two, okay, pwedeng mga situations that increases your intra-abdominal pressure. Can you give me some situations that increases your intra-abdominal pressure? Anong mga ano yon? Or sinong mga yon? What are the situations that might increase your intra-abdominal pressure? Pwedeng yung, yan, very good. Pwedeng yung merong tight clothing, correct? What else? Pwede din bang pregnant women? Yes. How about obesity? Yes, of course. Yan mga yan. Pwede din ba yung mga nag-gym at nagbubuhat ng sobrang bigat? Yes, okay, pwede rin yun, alright? So anything that increases your intra-abdominal pressure, especially if your LES are weakened already. Okay, meron tayong tinatawag na hiatal hernia, alright? I'll show you a picture. Okay, this hiatal hernia is a predisposing factor to your incompetent LES. When you say hiatal hernia, okay, it means bulging, which are common with your obese patients and pregnant women. So as you can see in the image, okay, this is a condition in which the upper part of your stomach bulges through an opening in your diaphragm. Okay? Since ang diaphragm naman natin, yun ang nagse-separate ng ating chest at ng abdomen. It's a muscle that separates our chest and abdomen. So, kapag meron tayong hiatal hernia, okay, lumuluslos, alright? Meaning parang nagbabulge siya upwards, yung upper part ng stomach natin, nagbabulge siya sa tabi ng esophagus natin. So we call that one sliding and paraesophageal hiatal hernia, all right? And it has the same effect, all right? It would backflow, all right? The acid or the stomach contents, all right? Inside your organ, all right? And that what will happen with our GERD. Now, ma'am, aside from the following situations, okay, aside from aging, pregnancy, obesity, and other situations that increases your intra-abdominal pressure, meron din tayong mga triggers. Okay, when we say triggers, foods, all right, that might worsen the condition of your GERD. Can you give me example? I've already gave you a mnemonic CASH. Okay, CASH is a mnemonic for your triggering factors. C, isa-isay natin. C stands for, C muna. Caffeine, very good. Coffee or no. Di ba yung iba dito, coffee daw ang nag-trigger ng kanilang GERD. Ano pa? Coffee, what else? Or caffeine. Carbonated drinks. What else? Include nyo dyan ng chocolates. And of course, how about citrus fruits or foods? Yan. Okay. Letter C. Copy this one. Caffeine, carbonated drinks, chocolates, citrus fruits. No. Okay. These are very acidic. Letter A. Anong A natin? Okay. Your favorite drink. Okay. Bawal yan ha. Pag may GERD. Avoid. Letter S. Kapartner ni alcohol. Kapartner ni alcohol. We have your spicy foods and smoking. Okay? Spicy foods, smoking, especially the nicotine, are irritants for your stomach. Bawal yan. What about letter H? H stands for hot, high-fat food. Okay, hot and high-fat food are no for your GERD. Ma'am, bakit? Alright? Can you give an example of high-fat food? Can you give me example of high-fat food? You can answer. You can guess. Yan. Iba, sinabi milk tea, yan. Pork, bulalo, okay? Yan, mga fried, oily, okay? Especially, of course, do not forget dairy products, okay? Are dairy products rich in fats as well? Yes or no? Is dairy product high in fats? Yes, okay. Is milk part of the dairy product? Yes. So, mali ba or tama na pinapainom tayo ng milk dati pag nag-ina-acid tayo? Is this correct management or wrong? Wrong, okay. It's actually a myth, okay. Dati kasi, 'di ba dati yun yung traditional practice nung before, alright? Old practice yung iba pag ina-acid umiinom ng gatas. Please take note that milk itself is a dairy product aside from containing lactic acid, it's also high in fats, okay? And fats, okay, remember, it delays gastric emptying. So even if it's chocolate or any milk product, all right, that contains fats, all right, it delays gastric emptying. Meaning, if it's delayed, will it be taken longer in the stomach? Tatagal ba siya sa stomach? It would take longer in the stomach. So will there be chances or possibility of GERD? Yes, of course. And we do not want that one. Okay, kindly include this one, tomato-based products or tomato-based food. All right. These are also rich in vitamin C, so it's also acidic. Okay, so bawal yung mga yan sa ating GERD, alright? So, ang ating cash diet, just a recap, letter C stands for caffeine, chocolate, cola, carbonated drinks, any soft drinks, yung mga yan. Alcohol, spicy, smoking, hot, high-fat food, alright? Citrus fruits and tomato-based products are not or should be avoided for your GERD. Is this part clear? Marami bang masasagot sa SATA sa NCLEX? Yes, kayang-kaya. No need to memorize. Basta alam nyo lang, cash diet. No. Alright. Okay, so what happens in our GERD? Alright? So, sa GERD, okay, nagkakaroon again ng HCl backflow. Alright? And if there's an HCl backflow, ano yung nagba-backflow? Ano yung nagba-backflow? Ano yung nagba-backflow? Yung laman sa stomach natin, alright? Including our HCl, alright? And that causes the hallmark sign, which is what we call our heartburn, alright? Heartburn is the hallmark sign for our GERD. Now, to prevent HCl backflow, what is the best position for the client? What's the best position for the client? Upright position or high Fowler. Now, kapag matutulog, okay, we could do 2 to 3 pillows or semi-Fowlers as long as you prevent the heartburn or your HCl backflow. If you've heard about this term, pyrosis, pyro means fire. So, fire parang nagbo-burn siya, di ba? Same term lang yan. It's also termed as heartburn, alright? So, pyrosis or heartburn is just the same meaning your HCl backflowed, alright? So, the best position for that one is remain upright, alright? And of course, avoid the triggers. Now, ma'am, bakit tayo nagkakaroon ng feeling of fullness? Bakit parang busog tayo pag nag-GERD, alright? Usually, syempre, nag-backflow yung acid, tama? Tsaka yung food natin. Anong mare-retain sa stomach? Solid, liquid, or gas? What will be retained in a stomach kung lumabas yung pagkain natin? Alright. We have a feeling of gaseous. So parang nararamdaman natin parang bloatedness. Aside from sumasakit yung tiyan natin, parang meron tayong gaseous feeling. Alright. Whenever there's backflow. Alright. So feeling of fullness happens in your GERD. So better to give sips of water. Alright. And small frequent feeding natin. Alright, for the client. Small frequent feeding only and sips of water. Alright? Now, for your nausea and vomiting as a common symptom for your GERD, we give your antiemetics, the following. We also have what we call your thialism. What do you mean by thialism? What is thialism? Ano yung thialism? Ano to? This is your salivation. Right? So, the acidity from the stomach. Sorry. Ayan, alright. So, the acidity from your stomach triggers our salivary glands, okay, to produce more saliva. Kaya sometimes parang naglalaway tayo pag may GERD, alright? So, as a management for that one, we can give mga sugarless gums, sugarless candies, and toothbrushing. Alright, that could be nursing management for your over-salivation. Alright? When you say dysphagia, what is dysphagia? Kapag nagsusuka tayo dito, ina-acid tayo dito, ano ibig sabihin ng dysphagia? Is this possible? Is this possible? Okay. So, to prevent, of course, or to manage your dysphagia, we usually give thickened fluids. Ma'am, ba't hindi thin? Bakit thickened? Alright? We flex the neck upon we tell the patient to flex the neck upon swallowing by giving of thickened foods and fluids to make sure that the food will reach the stomach and not the lungs. Kasi nga nagjo-jerk tayo dito, 'di ba? So we have the following again position: remaining upright during sleep, semi-Fowler, sips of water only, and small frequent feeding. We give your antiemetics, your sugarless gums and candies, and we flex the neck upon swallowing and giving off thickened foods and fluids as a management for your GERD. All right. So over time, question: can I add another symptom? Chronic GERD. All right. Over time ba pwede magkaroon ng hematemesis or vomiting of blood? Is it possible? Why? Kasi yung acidic content, 'di ba? Sobrang tapak niya, nai-irritate niya yung lining dun sa esophagus. Kaya minsan may parang dugo-dugo tayong nasusuka. Alright? So, best for that one, again, we want to prevent the backflow. So, ito ang best position. Remaining upright and 2 to 3 pillows upon sleeping. Alright? So, that would be for your GERD. Now, ma'am, we give your upper GI medications, yung pinag-usapan natin kanina. But, okay, worst case scenario, alright, we have what we call a surgical management that is used to treat our GERD and hiatal hernia. This is what we call our Nissen fundoplication. Have you heard about this word? Nissen fundoplication. This is actually a surgical management, alright, to treat your GERD and hiatal hernia. So as you can see in the picture, okay, di ba sa hiatal hernia parang nagbabulge yung stomach natin or yung upper part ng fundus ng stomach natin. So what will it do with your Nissen fundoplication? This is via laparoscopic surgery, alright? Tapos, iniikot niya yung stomach sa esophagus. Alright? Iniikot niya yung bulged part ng stomach. Alright? Tapos, tatahiin yan. Alright? To strengthen the lower esophageal sphincter. Again, this will tighten, alright, and reinforces the sphincter at the top of your stomach. So, another term for that one is what you call your gastric wrap around. So, from the term itself, the stomach or gastric part of your body will be wrapped around your esophagus to tighten the lower esophageal sphincter to prevent, okay, GERD or hiatal hernia. Alright, so that is your Nissen fundoplication. Alright, so let's now move on with your peptic ulcer disease. Peptic ulcer disease, ano yung ibig sabihin nito? Right? When you say peptic ulcer disease, what is this one? What do we mean by this one? Peptic ulcer disease. Anong meron dito pag may PUD? Okay. May sugat ba yung stomach? Yes or no? When you say ulceration, meaning there's wound, alright? There's sugat. Yan. So, pwedeng sa stomach, pwede din sa duodenum. Alright? So, it could be gastric ulcer and duodenal ulcer. Question, if there's wound, is there also bleeding? Pag may sugat ba, may bleeding? So, is it expected that there's bleeding with your peptic ulcer disease, whether it's gastric ulcer or duodenal ulcer? Yes. What must you check sa labs ni patient or kay patient? Anong dapat i-check? We monitor what? The hemoglobin as well as the hematocrit of the client. Now, what would be the complication ng ulcer? Ano pwedeng complication pag butas yung stomach, butas din yung duodenum? Aside from anemia, ano pa? Starts with the letter P. Okay, that would be your peritonitis, and we do not want to have that one. That's why we manage our peptic ulcer disease. Question, what causes our ulceration? Ba't nagkaka-ulcer tayo? Ano ba yung ginagawa natin? What do we usually do? What do we usually do? Ba't nagkaka-ulcer tayo? Can you give me examples of the causes? Lifestyle, alright? What kind of lifestyle? Pwede ba yung mga hindi yung mga nagda-diet tas hindi kumakain? Yan. Pwede din bang stress? Yes, pwedeng-pwede yan. That's one of the factors or risk factors for your ulcer. Stress ba tayo guys tonight? Are we stressed tonight? Kasi kinakabahan tayo, mag-NCLEX tayo. Are we stressed? Dapat hindi. Baka magka-peptic ulcer disease tayo. No. Tapos sinamahan pa natin ng coffee kasi every night may review, nagko-coffee tayo. Tapos ulam natin, spicy ramen. Yan, yun lang. Ayun. Oh. Trigger factor, right? I'm not saying automatic magkaka-ulcer ka, but it could be a trigger factor, right? So for your peptic ulcer disease, we have two. We have your gastric ulcer versus your duodenal ulcer. Now, for your gastric ulcer, ang nagkakos niyan usually, alright, would be those people taking long-term use of corticosteroids and your NSAIDs. Mind you, corticosteroids and NSAIDs are what? Why would this be, okay, a predisposing factor or factors? What are these kind of medications? These medications are so strong and also irritants to your stomach. Okay, these are GI irritants. That's why when you take this medication, okay, do you take it with or without meals? With meals dapat, alright? So, hindi, nag-take ka ng NSAIDs, nagsi-steroids ka, hindi ka, nag-gym ka kunwari, papalaki ka ng katawan, tapos hindi ka kumakain, nag-steroids ka pa, tas stress ka pa sa NCLEX, yan, tas inubos mo yung cash diet, ayan. Boom, gastric ulcer. Plus, you have history of gastritis. Yan, these are common, okay, causes of your or risk factors for your gastric ulcer. As compared to your duodenal ulcer, okay, it could also be a cause of your H. pylori. What is H. pylori? Ano yung H. pylori, guys? This is a kind of what? Bacteria, correct. Ma'am, pwede din ba siya sa gastric ulcer? Pwede rin. Alright? Pwede din yung H. pylori infection sa gastric ulcer mo. But the most common cause for your duodenal ulcer is this kind of syndrome, Zollinger-Ellison syndrome. Have you heard about this one? Zollinger-Ellison syndrome. Kung ang H. pylori ay bacteria, ano yung Zollinger-Ellison syndrome? This is a kind of what? This is a kind of tumor. Remember, this is a tumor. All right, so we'll discuss it later. And also, please take note, cash diet. Cash is also a predisposing factor, both for your gastric and your duodenal. All right, so let's talk about your gastric ulcer first. Okay, this is what you termed as poor man's ulcer. Poor man's ulcer. Okay, bakit? Okay, syempre kung ano lang naman to, hindi naman siya stereotype. Pero pag sinabing poor man's, di ba yung mga poor people, hindi nakakakain. Ayan. So, sa lifestyle, hindi sila kumakain. Yan. And also, alright, with the long-term use of your NSAIDs and corticosteroids as a major factor, okay, for your gastric ulcer, okay, nagkakaroon ng, alright, decrease in the mucosal lining of your stomach. That's why hindi siya hypersecretion. Pwedeng normal lang or hyposecretion ng HCl natin. Okay? The main cause would be long-term use of GI irritants. Alright? Kaya bumabawas. Alright? Or na numinipis yung lining ng stomach. Kaya nabubutas, nagkakaroon ng ulcer. Alright? It is not because of hypersecretion. Remember that, right? So, question, if there's ulceration, is it painful? Would there be pain present in the client? Yes or no? Yes, okay. Saan ba yung sugat? Where is the sugat? Where is the ulcer? What part of your body? Sa gastric ulcer? Sa stomach, okay. So usually, okay, the pain is felt upon eating, all right? During meals because the food, okay, natatamaan niya yung sugat. Alright? So, once we eat our food and swallow na natin, so during meals, doon natin na-feel yung pain kasi natatamaan natin yung ulcer part nun. So, pain during meals. So, as a relief for the client, okay, since sumasakit during meals, the client tends to vomit na lang. So, when we vomit the food, alright, would it cause weight loss or weight gain? Pag nagsusuka tayo, expect that there's weight loss, all right? And of course, what kind of bleeding will be seen to the client, okay? Kung injured na yung mucosa lining ng stomach, okay? Tapos dumadaan pa sa esophagus, anong kind of bleeding to? Hematemesis. When you say hematemesis, there's vomiting of blood, okay? Is it bright red or dark red? Bright, syempre, of course, kasi fresh pa yung dugo, okay? Together with your food content. So that is your gastric ulcer. Is this part clear, guys? Is this clear? Yes, okay, all right. So let's now move on with your rich man's ulcer, okay? Ito yung tinatawag nating duodenal ulcer. Ma'am, bakit rich man's ulcer? Ano bang itsura ng mga common rich people, all right? Na hindi nagpapabelo. Yung mga traditional mayayaman, sila ba yung mga matataba? Yes or no? Yan, kasi marami silang pangkain. Mukbang sila ng mukbang. Tama? Yes, may pang-food, may pang-ano sila, may pangkain sila. Plus, syempre, pag rich ka, dami mong business, dami mong inaasikaso mga negosyo. Are you stressed in life? Yes or no? Yes, okay. Yan, correct. So, pwedeng ito ang cause ng ating duodenal ulcer, stress factor, alright? So, aside from stress, please take note, one of the key factor for your having a duodenal ulcer is what we call your Zollinger-Ellison syndrome. When you say Zollinger-Ellison syndrome, this is a kind of tumor. Listen, this is a tumor found in your pancreas. Okay, so nasa loob siya ng pancreas. And then, etong tumor na to, nagse-secrete yan ng gastrin. Okay, when we say gastrin, okay, it triggers the production of your hydrochloric acid. Okay, so pwede siyang sa pancreas, pwede din siya kumalat hanggang sa duodenum nyo. Okay, so please take note that in your duodenal ulcer, alright, having Zollinger-Ellison syndrome plus your stress, and when you're stressed, your stomach will produce more and more and more acid. That's why sa duodenal ulcer, hypersecretion of HCl tayo. Alright? And pain is felt once the food have reached your duodenum. Okay? So, usually after meals pa natin mafe-feel yung pain. Now, as a result, okay, to relieve the pain, kakain na lang ng kakain si patient. Alright? So, will it cause weight gain or weight loss? When we tend to overeat, alright, so there will be possibility of weight gain. And since the ulcer already is in the first part of your small intestine, hindi naman na yan magba-backflow pataas. Bababa na yan to your large intestine. That's why the bleeding here, alright, would be what? Okay, would be the lower part. Okay, lower GI, upper GI bleeding, but going down, that would be your melena. And melena is what color? Black tarry stool, all right? So both have bleeding, so both you should monitor for the hemoglobin and your hematocrit. Now, To prevent that one, or to prevent your peptic ulcer disease, we give the following diet. Same lang sila. And we also avoid the following. It's also the same. We avoid yung cash. Okay? We avoid the cash lifestyle natin. Okay? When it comes to stress, wag tayo ma-stress. Usual. Ano naman to eh? Common naman sa atin to eh. So, avoid stress, avoid trigger factors, bland diet, and of course, monitor hemoglobin and hematocrit. Is this part clear? Common naman ang ulcer sa atin eh. No need to memorize. Just remember what would trigger our ulcers. Alright? And usually dito naman sa peptic ulcer disease, we actually differentiate gastric versus duodenal. Okay? So let's try to answer without looking at your notes if you've listened lang. Okay, let's just try to answer. Okay, as a class, please write your answer in the chat box. Pain during meals? Gastric, good job. Weight loss? Sino yung nagwi-weight loss? Sorry. No vomiting. Di nagva-vomit. Patient eats more to decrease pain. Duodenal. Weight loss. Weight loss, gastric. Sino yung nagvo-vomit? Gastric. Weight gain. Duodenal. Hematemesis. Gastric. Melena. Duodenal. Zollinger-Ellison syndrome. Okay. Avoid cash diet. Both. Very good. Okay. Good job. All right. Monitor for bleeding, hemoglobin, and hematocrit. Both. Good job. All right. Both yan na. Okay. So, is this part clear? Clear na ang gastric versus duodenal? Yes. Do you love gastro? Walang nag-answer. Dapat love niyo yung GI. Okay. Pag di nyo daw love, mas marami tatanong si NCLEX sa inyo. Alright? So, that would be for our peptic ulcer diseases. Alright? Now, if it's not manageable by your upper GI medication, okay, we usually do gastric surgeries. Okay? Especially pag meron ng gastric cancer, mga ganyan. Okay? So, for your gastrectomy, okay, pag sinabing ectomy, what do we mean by ectomy? Removal. What did we remove here? Stomach. Okay. So, we have two types or two kinds of gastrectomy. We have total and we also have your partial gastrectomy. When you say total gastrectomy, the entire stomach is being removed. Alright? Ano ba yung connecting organs ng stomach natin? What are connected with our stomach? Yung upper and lower part ng ano natin. Yan, okay. Esophagus and your ating duodenum, okay? Which is first part ng ating small intestine. That's why when we say total gastrectomy, okay, it's also termed as esophagoduodenostomy. Esophagoduodenostomy, meaning, okay, your esophagus is anastomosed to your duodenum, which is first part of your intestine. So, nawala ng stomach natin dyan. Alright? That's your total gastrectomy, also termed as esophagoduodenostomy. We also have your partial gastrectomy. When you say partial, we did not remove the entire stomach. What we removed only is a part of your stomach. Na sabihin natin may ulcer or may cancer, ganyan. And we have two types of partial gastrectomy. We have your Billroth 1 and your Billroth 2. Okay, Billroth 1 and your Billroth 2. Now, for your Billroth 1, okay, we have this is also termed as gastroduodenostomy. For your Billroth 2, gastrojejunostomy. Ayan, alright? So, for your Billroth 1, okay, it's called gastroduodenostomy, meaning, okay, since we just removed a part only, there's still gastric remnant, alright? May na-retain na part ng stomach. So, that retained part or your gastric remnant will be, okay, anastomosed or will be connected to your duodenum. And that's for Billroth 1, alright? For your Billroth 2, alright, gastric remnant will be connected to your jejunum. Hence, it's called gastrojejunostomy. Is this part clear? Billroth 1 versus Billroth 2. And there's an image in your in the screen. Billroth 1 is this one, all right? This on your left lower, all right? That's your Billroth 1. On the opposite, we have your Billroth 2. Okay, the stomach is connected to your jejunum. Now, since we remove the entire stomach or we remove the part of your stomach, okay, will it serve its entire purpose of digestion for 30 minutes to an hour? Yes or no? Am I talking to someone? Again, pag ni-remove ba yung part ng stomach or ni-remove yung entire stomach, okay, will it serve its purpose of complete digestion for 30 minutes to an hour? Hindi, okay. Anong pwedeng complication for that one? Dumping syndrome. Now, for total gastrectomy, okay, tinanggalan natin ng buong stomach, okay, makakapag-produce pa ba tayo ng intrinsic factor? No. So, anong pwedeng another complication for that one? We could have your pernicious anemia. Good job. All right? So, for your vagotomy, when you say vagotomy, we remove the vagus nerve. Okay? Again, vagotomy is the resection of your vagus nerve because your vagus nerve also triggers the production of your hydrochloric acid. Okay? So, we remove that cranial nerve number 10. Okay? Tanggalin din natin yan. Now, what I want you to focus on would be our complication pag tinanggal na yung stomach natin. So, effects of your gastric surgery. Let's talk about your pernicious anemia. I'm not sure if you're done with your HEMA, alright? But let's just have a recap. So, post-gastrectomy, tinanggalan ng stomach, alright? So, whenever there's no more stomach, okay, did we also remove the parietal cells? Did we remove the parietal cells when we remove the stomach? Yes, wala nang production ng parietal cells. So, pag wala nang parietal cells, okay, wala na din bang intrinsic factor? Yes. So, pag walang intrinsic factor, will it be able to activate your vitamin B12 for absorption? No longer, alright? Hence, we could have this kind of anemia, pernicious anemia. Ma'am, bakit anemia? Kasi vitamin B12 is a vitamin of your RBC, needed for its growth and development. So, what would be your assessment for the client? Of course, anemia, pwede magka-pallor, alright? Since RBC carries oxygen and energy, mabilis mapagod si client, alright? Hallmark sign for this one would be your beefy red tongue, okay? And of course, paresthesia. Paresthesia, as a sign for that would be your numbness, tingling, okay, paralysis. Why is that so? Ba't tayo nagkakaroon ng paresthesia sometimes when we have pernicious anemia? Ano ba yung hindi natin na-absorb? Dito, sa pernicious anemia, ano yung hindi na-absorb? Vitamin B12. Is vitamin B12 part of vitamin B complex? Yes, vitamin B complex are or works on what? Our what? Our nerves. Okay, it works on our nerves. Kaya tayo nagkakaroon ng paresthesia here in your pernicious anemia. Now, we do not have a stomach, we do not have parietal cells, we do not have, hence we do not have intrinsic factor, all right? So we won't be able to absorb or activate our vitamin B12. Even if we eat a lot of vitamin B12 rich foods, or even if we take vitamin B12 tablets orally, okay, hindi na siya maa-absorb, okay? Because your intrinsic factor, that's the one that will activate the vitamin B12 for absorption. However, if we do not have a stomach already, we need now an active form, all right? And as a management for that one, since kailangan natin ng vitamin B12 at kailangan natin active form na, we need to give your vitamin B12 via IM injection. Question, is this for life? If we have pernicious anemia? Yes. So initially, for the first month, we give it weekly. So that's every month. So sa first month, ilang beses siya binigay? Kung weekly. Every week. 4 times. So for the consecutive months, second month, third month, fourth month, fifth month, for life, we give it monthly, every month na. Again, this is lifetime to prevent signs and symptoms of your pernicious anemia. Is this clear? Is it clear? Yes. Okay. Again, do not forget, this is for life. This is lifetime IM injection of your vitamin B12. Now, let's now move on with your dumping syndrome. Pag sinabing dumping syndrome, from the word itself, what happened? What is dumping syndrome? Or what happens in dumping syndrome? As an effect of your total gastrectomy. It's a syndrome wherein foods are what? It's a syndrome wherein foods are what? Diba pag nagda-dump tayo, big sabihin, okay, mabilis bumaba. Correct, Sir CJ. Alright, dumping, nag-dump right away. Okay? So since we no longer have a stomach, okay, do we have a storage? Kung wala na tayong stomach, do we have a storage? No. So from the food coming from our esophagus, saan na siya mapupunta? Duodenum, okay? So anong food ang napunta sa duodenum kung wala ng stomach? Digested or undigested? Undigested. Is it a problem? Yes, okay. So what will happen in our dumping syndrome, alright? Ito yung mga mafe-feel natin. Alright? Abdominal fullness, parang feeling natin busog tayo right away because nag-dump nga siya. Plus abdominal cramping kasi nga hindi na-digest yung food natin. Alright? Bolus did not turn into chyme, so there's abdominal fullness and cramping. Alright? We could also experience diarrhea. Ba't tayo nagkakaroon ng diarrhea? Kasi bumibilis yung peristalsis natin because of our undigested food. And let me add on this one. Alright, let me add on this one. We could also experience hypoglycemia. Are you done with your endo? Are you done with your endo? Okay, anyway, hypoglycemia, okay? Ang mga signs and symptoms niya would be what you call your tired, okay? Ano yung tired? We have your tachycardia, irritability, okay, restlessness, yan, excessive hunger and diaphoresis. Okay, that's why additional symptoms for your hypoglycemia in terms of your dumping syndrome would be the following. Okay, so aside from diarrhea, pwede tayo magkaroon ng tachycardia, palpitations, and severe sweating. Ma'am, ba't nagkakaroon ng hypoglycemia? Isn't it that we have a bulk of undigested food? Tama? Yes or no? Okay. Now, since hindi na-digest, okay, yung food natin, possible ba na hindi natin madadigest yung carbs? Is it possible na there's undigested carbohydrates? Correct. So, since yes yung sagot nyo, okay, since we have an increased undigested carbs, okay, matitrigger yung pancreas to produce more and more insulin. That's why we are having hypoglycemia. Okay? Nagko-compensate si pancreas to produce more insulin. Hence, we could experience palpitations, tachycardia, perspirations, alright, with your dumping syndrome, aside from the given assessments, alright? So, to prevent that one, to prevent rapid gastric emptying, okay, what must be given to the client? Increase carbs or decrease carbohydrates? What diet? Increase or decrease carbs? Low carb tayo. Okay? We are not treating our hyperglycemia here. No, this is just a complication. So we decrease the carbs to prevent hyperinsulinemia. Okay? So low carb diet. Okay? However, we give diets that will delay gastric emptying, and those diets are our protein and our fats. So remember, the diet in our dumping syndrome are low carb but high protein and high fat. High protein and high fat would delay gastric emptying because that's what we want to prevent in dumping syndrome. We want to prevent rapid gastric emptying because of dumping of undigested food. All right? When it comes to feeding, we do small frequent feeding. Okay? Kasi nga ayaw natin mag-dump right away yung feeling. So we want to prevent abdominal cramping and fullness. Okay? Ma'am, paano natin mape-prevent yung dumping syndrome? Aside from the diet, what position is best for dumping syndrome? Yan, lie down. Paano pagkakain? Pwede bang up to low Fowlers? Yes, okay. So after eating, of course, syempre, lie down tayo or supine for at least 30 minutes to 1 hour. Huwag tayo mag-ambulate, okay, to prevent dumping syndrome problems. Is this part clear? Is this clear? Yes. Alright. So before we proceed with our accessory organs, mamang fluids ba in between? Sips of fluids tayo. Sips of fluids. I'm not restricting fluids, pero sips of fluids lang. Right? Okay, alright. So let's have a break lang, bladder break. Okay, is 3 minutes okay with you? Bladder break muna. Okay. So I'll be back after 3 minutes. Okay, shall we continue? Alright, so let's now move on with our accessory organs. Tapos na tayo sa upper GI, alright? Let's now move with our accessory organs. When you say accessory organs, these are very important organs, okay, that helps with the digestion, with the with our upper GI and lower GI system. All right? So, very important is we talk about the physiology or the functions of our accessory organs. Can you give me examples ng ating accessory organs? What are our accessory organs? As seen in the screen, ano tong mga to? Very good. Liver. What else? Gallbladder. Correct. Ano pa? And our part of our gallbladder would be our common bile duct and of course our pancreas. Alright? So I want you to focus on this one, alright? The anatomy and physiology ng ating accessory organs. Dahil pag alam natin yung normal function, alright, we would be able to determine how we will manage the disorders, okay, in relation to our accessory organs. Now, for the liver, please take note that this is one of the major or vital organs of our body. Again, this is very important. Okay, ang ating liver. Do you take care of your liver, guys? Do we take care of our liver? Dapat, alright? Because again, it has many functions. Sabi ni Jo Marie, hindi daw. Bakit, sir? Dapat liver lover tayo, guys, ha? Very important kasi makikita niyo ang dami niyang function. Okay, number 1, please take note. Our liver produces bile. Again, our liver is the one that produces bile, not the gallbladder. Okay, ano lang ba yung gallbladder? Gallbladder is just a reservoir or a storage. So, ma'am, what is bile? Can you help me answer? What's bile? For what bang bile? Bile is a fluid made and released by our liver, okay, that help us emulsify our fats. Okay, good job. It's fat emulsification. So, ina-emulsify or binibreak down niya yung fats into fatty acids that are taken by our body for digestion. Again, si liver ang nagpo-produce nito, hindi si gallbladder. Next would be, okay, liver is also responsible for the conversion of the byproduct of our protein metabolism. Again, liver is responsible for the conversion ng ating protein metabolism, yung byproduct nun, alright? So, it helps with the protein metabolism. And as a byproduct of our protein, okay, nagkakaroon tayo ng waste material doon, okay? Once the protein is being metabolized, we have this termed waste material that starts with the letter A. What is that? What A is a byproduct of protein. It's not ADEC. ADEC is a vitamin, all right? Or ADEC are vitamins. Okay, good job. That would be our ammonia, okay? Is ammonia a waste product? Yes or no? Yes. So kapag waste product, dapat ba tinatapon na siya? Mga waste sa buhay natin, dapat ba hindi na natin binabalikan? Dapat tinatapon na natin yung mga waste natin. Mga pagkakamali natin noon. Yes, of course. So, in order for us to remove that waste product, okay, yung liver natin, hindi natin kasi na excrete yung ammonia automatic, okay? The liver converts that ammonia, okay, into urea with the help of your kidneys, okay, in order to excrete that one. Again, liver, okay, converts, okay, the byproduct of protein metabolism, which is ammonia, a waste product, that will be converted into urea, and with the help of our kidneys, we could excrete that one. Okay? So, itatapon na natin yung waste material via our urine, of course. Alright? So, it works together with our kidneys. Now, another function of your liver is absorption ng ating fat-soluble vitamins. Can you help me? What are the fat-soluble vitamins? Yes, okay. That would be our vitamins A, D, E, and vitamin K. Good job. And also, any drugs that are taken, okay, kahit anong drugs na tinitake natin, it's the liver's responsibility to remove its toxins. Okay, so again, dapat mahalin natin yung liver natin. We should love our liver because it has so many functions. All right. Now, if there are any disorders related to our liver, we have the following. We have the common or the famous hepatitis and liver cirrhosis. So, pag-uusapan natin to one by one. That would be for our liver. For the gallbladder, okay, again, as you've said, this is also it also helps the liver's bile, okay, by storing it or storage of bile. All right, disorders related to that one would be, all right, formation of gallstones, which is cholelithiasis, and inflammation of the organ itself, cholecystitis. So ito yung mga pag-uusapan natin mamaya. Last accessory organ would be our pancreas. Is pancreas also a vital organ or an important organ? Yes, kasi pancreas, okay, marami siyang function. It has both endocrine function and it also have an exocrine function. For the endocrine function, I leave that one to your endo lecture, all right? But for the purpose of our GIT, okay, we will discuss the exocrine function of your pancreas. And when we say exocrine function, we will be focusing on the digestive enzymes produced by this organ, okay, which is our amylase, lipase, and protease, or our trypsin. Amylase are enzyme that digest what? Food. Ano tinitake natin na dinadigest ni amylase? Carbs, protein, or fats? Amylase, carbs. Lipase, lipids. Ano dinadigest nito? Fats. And your protease or your trypsin would digest our protein. Good job. Now, if there's inflammation, okay, of your pancreas, we call that one your pancreatitis. Your pancreatitis. Okay, so that would be for your accessory organs. Sa pancreas, yung endocrine function niya, common disorder dito yung DM natin. Okay, so more on sa endo system yan pag-uusapan. Alright, so for our GIT, we'll be talking about our pancreatitis here. Alright, so let's start off first with our major organ, liver biopsy. Okay, what's the best position? Okay, pre or bago mag-liver biopsy. Should we expose the liver? Saan ba located ang liver? Saan located ang liver? In your right? Okay. Upper quadrant. Alright. So, of course, we want to expose that part by putting your right hand under your nape or your buttock daw. Okay. Through exposure or left side lying. Procedure is during the pre muna we assess of course our prothrombin time because our liver is what? But kailangan i-assess ang ating PT time. Highly vascular. Okay? What kind of anesthesia? Local anesthesia. So during the procedure, we inhale, we instruct the patient to inhale, exhale, then hold breath for 5 to 10 seconds to prevent puncturing of the lungs, all right? And then after liver biopsy, why is it needed that we tell the patient to do right side lying plus yung iba sandbags yung binibigay? Bakit? To put what? To put pressure and to prevent bleeding. Okay, good job. All right. So let's talk about the first disorder for our for our liver. That would be your hepatitis. When you say itis, what do you mean by itis? Inflammation. Ano yung hepa? Ano yung inflamed? Ano yung inflamed liver? Alright. So why is it that our liver has inflammation? Okay, we have the following, alright, types of hepatitis. We have Hepa A, Hepa B, C, D, and E. Okay. These types of hepatitis have different risk factors and route of transmission. Alright. So usually yung Hepa vowels natin, Hepa A and Hepa E, saan nanggaling to? Saan nanggaling? Ba't tayo nagka-Hepa A and Hepa E? Contaminated food or water, alright? Saan tayo usually kumakain? Pwede ba ito makuha sa mga street food, sa Hepa Lane? Yan, dyan natin yan nakuha. Isaw. Do you love isaw? No. Siyempre yung nagtitinda, hindi natin alam. Baka meron siyang hepa, tapos di siya nagugas ng kamay, tapos boom, kumain tayo ng street food. Hepa B, C, and D, or meron ding Hepa F nga eh. Hepa consonants, what are the similarities for this one? How did we get Hepa B, C, and D? Of course, mga blood-borne, alright, diseases and viruses as well, alright? So usually, we get infected with this one via what? Anong mga situations? Unprotected sexual intercourse, pwede din yung pwede ba yung mga needle pricking? Yan, okay. So, dyan natin nakukuha. Kaya medyo sa hospital setting, we do prophylaxis. Lalo pag nag-take care tayo ng patient na may exposed tayo sa HEPA. Alright, now sorry, can I just add another kind of hepatitis? Lanex hepatitis. What do you think is the cause for your Lanex or Lanex hepatitis? Anong common cause niyan? Favorite drink nyo? Yan, good job. Yan, pwedeng alcohol ang mag-cause ng inflammation. Alright? So we have that kind of HEPA. Pwede din ba yung mga hepatotoxic drugs? Or toxic sa ating liver? Alright? Can you give me example of hepatotoxic drugs? Good job. We have your NSAIDs, TB drugs, okay? Yung mga birth control pills, yan. Tsaka yung ating oral hypoglycemic agents. Those are kind of hepatotoxic drugs that must be avoided when you have already your hepatitis or must be taken precaution, okay? Once we do that one or once we take that one. Now, we would wanna assess the client. Say, for example, meron tayong friend, okay? Sige, wag na lang friend, enemy na nagka-HEPA. Yan. Tapos, alright, nahawaan siya. So, hindi siya agad, ano bang color pag may HEPA? Anong color ni client pag may HEPA? Jaundice or yellowish. Now, kapag na-expose siya, say for example, sa virus na yon, sa HEPA virus, right? Hindi siya agad automatic jaundice, okay? Meron stages of hepatitis. We have pre-icteric stage, we have your icteric stage, and we have your post-icteric stage, okay? With your pre-icteric stage, this usually, okay, is 2 weeks after the exposure. Alright, this is the pre-stage. Hindi pa agad jaundice to. Tandaan nyo. What will the patient feel? Okay, since nagkakaroon na ng start of liver inflammation, okay, meron tayong mga flu-like signs and symptoms. Can you give me examples of flu-like signs and symptoms? Pwede siya magka-fever, ano pa, body malaise, chills, loss of appetite, nausea, vomiting. Yun yung mga first stage na ma-feel niya, flu-like signs and symptoms. Aside from that, when you check the liver test, okay, or liver function test, mataas ang kanyang ALT at AST. Alright? So, when you check it, we have an increased liver enzymes due to liver inflammation. All right. And of course, it's also painful. The client will feel the pain in the location of your liver, which is your right upper quadrant pain. Again, these are symptoms and assessments on your pre-icteric phase or your pre-icteric stage, infective stage, or 2 weeks after exposure to your hepatitis. Now, when you say icteric stage, this usually happens 120 days after. Mga ilang months yon? 120 days. 3 to 4 months, okay? Usually 3 to 4 months. Okay, dito na nagkakaroon ng icteric stage. When you say icteric, okay, icterus, pag sinabing icterus, it means this is the jaundice or the yellowish stage, alright? Ma'am, bakit yellow? Bakit parang sa HEPA, yellowish si client, alright? This is because it's associated with your RBC hemolysis. When you say hemolysis, namatay yung RBC natin. And the lifespan of our RBC, it's usually 120 days. Okay, yan ang lifespan ni RBC. After 120 days, gagawa na naman ng blood sa katawan, si bone marrow, after 120 days. So during those days, okay, once the RBC hemolyze, okay, or breakdown, namatay, alright, there is a byproduct called bilirubin. Okay, tandaan nyo, once the RBC has been broken down, okay, there will be a byproduct called bilirubin. Okay, and when you say bilirubin, okay, that one, okay, is being converted by your liver, alright, from unconjugated bilirubin into conjugated bilirubin. Again, once the RBC after 120 days have been nagkaroon na ng lysis or breakdown, okay, or namatay, okay, there's a byproduct called bilirubin. And the function of your liver is to conjugate that bilirubin, meaning it will convert unconjugated into conjugated bilirubin for excretion. All right? Now, once it's already conjugated, that gives the normal color of your stool, your urine, and your bile. What's the normal color of your stool, urine, and bile? Stool muna. Anong normal color? Brown. How about urine? Urine. Normal color natin. Yellow. How about your bile? Green. Okay. Pag normal people or pag normal yung liver ng taong yon. However, when you have a liver inflammation, okay, hindi nako-conjugate ni liver kasi may sakit si liver dito or inflamed ang liver natin dito. So, the bilirubin, okay, will just retain in the blood. Hence, we would have an increased serum bilirubin, and that gives us, and that will deposit in our skin, giving us jaundice and pruritus. So, when you say pruritus, itchiness, okay? It's kind of bit itchy feeling, and jaundice would cause us to have a yellow skin, all right? Also, okay, since it's in the blood, ang nagfi-filter ng blood natin, yung kidney, okay, pagkalabas ng urine natin, it's tea-colored. It's not normal, alright? And for your intestinal bile, okay, we have a clay, hindi na pupunta yung bile sa ating intestine, so hindi siya nagkakaroon ng normal color ng stool, so nagkakaroon tayo ng clay-colored stool. I'll show you a picture. Yan ang hepatitis icteric stage. Again, icteric stage is associated with your RBC lysis or RBC breakdown. Okay, so the byproduct of that one is your unconjugated bilirubin. So the liver won't be able to convert it into conjugated bilirubin for excretion, all right? Therefore, there will be no normal color of our urine, hence tea-colored urine sa HEPA, clay-colored stool, and of course, jaundice and pruritus for your patients, all right? Now, for your post-icteric stage, all right? Post-icteric stage meaning yung liver natin, okay, has the capacity to regenerate itself, all right? So, medyo gumagaling yung liver natin, kaya nagkakaroon tayo ng cessation of signs and symptoms plus generalized fatigue. So, this usually happens after 6 months or longer time, okay? When our liver starts to heal, all right, or regenerate. So that's your post-icteric stage. Now, as a management for the diet kay hepatitis, this is usually the opposite of the diet for your dumping syndrome, okay? Tataasan natin yung carbs, bababaan natin yung protein at yung fat intake. Bakit? From the normal function of your liver, okay, isn't it that our liver produces bile, yes or no? Yes, okay. Since we have a liver inflammation, may sakit si liver natin, hindi niya nagagawa yung function niya. So, hindi nahihirapan tayo mag-breakdown ng fats or mag-emulsify ng fats. So, we give low-fat diet. For the protein part, anong problema? Bakit low protein tayo? What is the purpose of our liver when it comes to protein digestion and metabolism? As what we've discussed a while ago. Ayan. So, syempre, we wouldn't want ammonia to increase, okay, in our or there's no conversion happening because our liver is inflamed, all right? So we want to decrease the workload of our liver by lessening, okay, the intake of fats and protein. Ano na lang kakainin ni patient? Carbs. Okay, syempre kailangan pa rin niya kumain. So bigyan na lang natin siya ng carbs. Of course, for energy as well. Now, for your another medication, we also have your interferon immunoglobulin. Okay, now if the cause is viral, all right, we give your antibiotics and your antibodies, your interferon immunoglobulin, if the cause is viral. For your cholestyramine, okay, this actually helps treat the pruritus of your client. All right, yung ating cholestyramine, yung pangangate. So that would be for the phases of your hepatitis, pre-icteric and your post-icteric. Is this part clear, guys? Clear ba to? Yes, okay. So let's now move, I'll just add additional management for your hepatitis. So these are the following. Again, diet, high carbs, low fat, low protein. What kind of precaution for hepatitis? Anong precaution natin for hepatitis? Standard precaution. Okay. Under standard, we have your contact prec. All right. So, of course, strict hand washing, prophylaxis, Hepa A, Hepa B vaccines, avoid sharing of personal things, and of course, avoid as well hepatotoxic drugs. All right. So, again, these are your additional management for your hepatitis. All right, so let's move on with your liver cirrhosis. I will finish your liver cirrhosis before you take your break. All right, so para hindi tayo mabitin sa liver. All right, so for your liver cirrhosis, when you say liver cirrhosis, this is actually irreversible stage. Okay, this could be a complication, okay, of your untreated hepatitis. And of course, a complication of long-term or chronic what? Anong tinitake natin? Ba't tayo nagkaka-liver cirrhosis? Complication of your hepatitis and chronic what? Chronic alcoholism. Good job, alright? So here in your liver cirrhosis, remember, your liver is no longer inflamed, okay? But rather, scarred na siya. Scars. Di ba para tayo pag nagsusugat tayo, di ba alam niyo yung feeling ng may scar? Yes, that's our liver cirrhosis. Scarring of our liver, alright? Now, due to chronic liver disorders, alright, nagiging fatty yung liver natin. Hence, nagkakaroon tayo ng process called fibrosis. Pag sinabing fibrosis, okay, napapalitan yung normal tissues ng liver natin. Okay? Which is connective tissues. Pinapalitan na siya ng connective tissues when supposedly it should be fibrous tissues. Now, since this replaced tissues is not the same as the actual tissue, okay, yung scars na yon or yung scarred liver natin na napalitan nung tissues na yon is already hardened, medyo matigas. Okay? So, pag matigas yung tissues na yon, would it cause obstruction? Yes or no? Yes, especially in our portal vein. Okay? So, there will be chances of portal hypertension. Again, normally, okay, this replaced tissues, okay, is not the same as the actual tissues. Okay? So, these tissues, up after this fibrosis stage, okay, yung tissues na yun tumitigas. Okay? That could cause obstruction in your portal vein. So, wala masyadong blood na bumabalik sa puso. Alright? Hence, we could have portal hypertension as one of the major symptom or nakikita sa ating liver cirrhosis. Now, anong mangyayari? Before we go to that one, ano mangyayari pag may obstruction sa portal vein? So, tignan nyo tong image na to, itong liver, alright? So, say for example, yung blood dumadaan sa portal vein, tama? So, pag may obstruction dyan, may traffic, okay? Kunwari sa NLEX, may traffic. Saan tayo dadaan? Pag traffic, okay? Dadaan tayo sa service road, okay? Para makapunta tayo sa destination. Now, with your portal hypertension, remember, the blood can't flow smoothly in our portal vein, the big vein, alright? So, it will look for other routes, other daan, okay? Like your esophageal veins, or veins in your stomach, in your intestine, and so on. And this kind of veins are smaller than our portal vein. Meaning, okay, since maliit lang tong mga veins na to, it will only accommodate a certain blood pressure. Alright? So again, it can only accommodate certain blood pressure. So over time, when this blood passes through different routes, okay, these veins could lead to swelling. And this will put too much pressures on the vessels, right? So if it's swelling, could it cause dilation? Yes or no? Alright, so if it's dilated, could it cause bursting? Pwede mag-burst? Could it lead to bursting? Yes. Is that dangerous or fatal? Yes. All right. So that would be one of our complication. Can I just repeat? Okay. Again, in your liver cirrhosis, okay, due to the scarred liver, okay, there's obstruction happening in our portal veins. So the blood, okay, instead of going back for the blood to return to the heart, all right, there will be other passageway, okay, that might be needed for our blood to return to the heart. So it will go to the esophageal veins, it will go to the stomach veins, to the intestines, and so on. And this kind of veins say for example, your esophageal veins, okay, can only accommodate a certain pressure. So if there's too much pressure of blood happening in your esophageal vein, this could lead to swelling. Swelling could lead to dilation, and worse dilation could lead to worse bursting. All right, and that's one priority for your liver cirrhosis, which is what we call your esophageal varices. Again, due to obstruction of your portal vein. All right? So if it ruptured, if it burst, okay, could it lead to bleeding? Yes. So since the bleeding is in the esophagus part, what's the danger there? Aside from shock, since it's in your esophageal veins. Okay, what's the danger if it bursts, if there's bleeding? Okay, there will be airway obstruction. All right. Now, for your esophageal varices, since we have a vasodilated veins, we need, of course, a potent vasoconstrictor. So we give your vasopressin. All right. Now, we also have what we call your Sengstaken-Blakemore tube. Okay, I'll just show you a picture, all right? So this is your Sengstaken-Blakemore tube, all right? This is actually used for what? To compress dilated veins, all right? So we put pressure by inflating two balloons, all right? However, all right, this is still a foreign material, all right? Can the balloon pop? Yes or no? Yes. Now, if the balloon pop, could it also cause airway obstruction? All right. Now, what must we have emergency at bedside to deflate those balloons? Good job. So you must have scissors at bedside for emergency purposes. Again, for your liver cirrhosis, this is one of your priority, your esophageal varices, because this could lead to your shock and your airway obstruction. So we check also your vital signs for the client. All right? For your next complication, aside from esophageal varices, we could also have ascites. Have you heard about this one, ascites? What is ascites? What happens in ascites? This is also caused by your portal hypertension. Okay. This leads to the decrease of your oncotic pressure. Again, portal hypertension leads to the decrease of your oncotic pressure or the pulling force, and increases your hydrostatic pressure or the pushing force. So it's no longer balanced. The water is being pushed, so there's leakage of fluids in your peritoneal space. Okay, hence we have your ascites. Now, if there's ascites, I'll show you a picture. This is what it looks like. Have you seen someone who has ascites? Yes. Now, for your ascites, what could actually happen? All right. Since you have too much fluid accumulation, all right, is it possible that we could have dyspnea or difficulty breathing for the client? Yes. All right. Now, to relieve the dyspnea, okay, what must be done, or what invasive procedure must be done to relieve the dyspnea? It starts with a letter P. We call that procedure paracentesis. Very good. Paracentesis is what? As you can see in the picture, there's a needle inserted there, okay, to drain the fluid, okay, and to help ease the shortness of breath and the difficulty of breathing for the client. Good job. All right. So before that, all right, management, we give your diuretics, okay, to remove the fluid. We also give your albumin IV. When you say albumin IV, okay, this actually increases the oncotic pressure, meaning it increases the pulling force, all right? So there will be less fluid leakage. Now, again, for your paracentesis, the goal dyan is to relieve the dyspnea. So, what must be done prior to inserting the needle? What must be done? We must what? We do what? We empty the bladder, okay, to prevent puncturing of the bladder. What's the best position for that one? Okay, sitting. Supine could also be, all right? Do we need to monitor the BP of the client? Why? Okay, there will be, of course, to prevent fatal hypotension, all right? And as we drain the fluid, usually it's 2 to 3 liters of fluid. Now, since we're still inserting a foreign material, which is the needle, all right, to prevent bacteria, all right, or peritonitis, what is our prophylaxis? We give your neomycin to achieve, again, our goal to relieve the dyspnea for your clients with ascites. Is this part clear? Yes, right. So again, this is how it looks like. It's like you're pregnant, but there's no baby inside. It has so many fluid or leakage of fluid. So we drain that one, all right? Now, of course, we wouldn't want to forget also the last complication, which is your hepatic encephalopathy. When we say hepatic, what organ is involved here? Hepatic. Liver. When we say encephalopathy, okay, which is affected? Our brain. So, ma'am, what happens here, all right? There's actually an increase in the ammonia level. Why? Because our liver, again, is sick, all right? Or we have a disease in the liver, we have liver cirrhosis. So, again, there's no conversion happening, all right? In order to excrete this kind of waste material, our ammonia, all right? And since you know that ammonia can cross the blood-brain barrier, all right? Our brain would be affected with this waste product, all right? Hence, we could have altered level of consciousness. Can you give me examples for signs and symptoms of decreased level or altered level of consciousness? What can we see with the client? Lethargic, what else? What else? Confusion, headache, restlessness, and so on, which will lead to coma. All right? Now, if the ammonia level is in the brain, we check for altered level of consciousness. When it also reaches our spinal cord, since our spinal cord has spinal nerves, our nerves are also affected. That is why we have what we call your hyperreflexia, all right? Our reflexes are compromised. Therefore, we have this term called asterixis. Okay, when I say asterixis, this is how it looks like. That's the hallmark sign of your hepatic enceph. This is your hand flapping. And we ask the patient to raise his or her left and right hand, and then you can see that one will happen to the patient with asterixis, involuntary flopping of hands, right? So, all right, to manage your hepatic enceph, since you know already the cause, all right, what must be done? Since there's increased ammonia level, do we need to get rid of your ammonia? Yes, how? By giving lactulose, all right? When you say lactulose, what is this? What is lactulose? Lactulose is what? It's an osmotic laxative, okay? What does it do with your hepatic enceph, okay? It helps excrete ammonia together with your stool, all right? And to determine effectiveness, all right, I'll write in the chat box, to determine its effectivity or effectiveness of lactulose, what must you see or what must you see to the client, or what must you observe in the client? There must be improvement in the level of consciousness, so that you would know that you've already excrete ammonias. All right, so check improvement in the level of consciousness for the client. All right. Next, we also give your neomycin. Neomycin is given to eliminate normal GI flora. All right. Normal GI flora is our normal bacteria. All right. That actually increases, okay, the production of your ammonia. Okay. So we remove your normal GI flora, right, to prevent increase of your production of your ammonia. Right, so that would be your management both for your lactulose and neomycin for your hepatic NSF. Again, we give your lactulose to excrete ammonia together with your stool. So what must you check? All right, sa client, we check improvement in the level of consciousness. So that would be for your hepatic NSF. Is this part clear? Is this clear? Yes. Okay. What is this again? What hallmark sign is this again? This is what you call your hyperreflexia, or what? Asterixis. Okay. In your, due to what? Why do we have asterixis? Due to increase? Due to increase ammonia levels. Good job. And that is your liver cirrhosis complication. All right. So it's already 8 o'clock or 8:02. I'll give you a 15-minute break. I'll be back, and then we will discuss pancreas onwards. All right. So 15 minutes. Be back around 8. Time is it? 8:18 p.m. All right. So if you have extra time, you can study the previous lessons. All right. So 8:18 p.m. Okay. 15 minutes. Okay, so are we guys back? Can we continue? Shall we continue? Okay, so now we will be talking about the disorder of our pancreas. All right. So before we begin, can I ask again a recap of the normal and exocrine function of your pancreas? What does our pancreas produces in terms of our GIT? All right, our digestive enzymes. Good job. Now, when it comes to pancreatitis, what is itis again? What's itis? Inflammation. And what is inflamed here? Our pancreas. Can you give me the reason why our pancreas can be inflamed, or what lifestyle, what risk factors might lead to pancreatitis? Can you guess? Chronic alcoholism, good job. And of course, if there's presence of gallstones, okay, that might also interfere, all right, and cause pancreatitis. So, do we need to get rid of alcohol from now on? Because we've learned so much of its effects from the liver and now the pancreas. Should we get rid of alcohol? In moderation as per Aris. Wow. Okay, now if you have pancreatitis, avoid already because it's one of the major cause, okay, of this inflammation, our pancreatitis. So let me just define it, all right? What happens in your pancreatitis? Inflammation of your pancreas. So our digestive enzymes are activated before they are secreted in our small intestine, which is our duodenum, and begin attacking the pancreas. So you might as well expect an elevation of your enzymes such as your serum lipase and your serum amylase. These again are elevated in your pancreatitis. Increase in your amylase, increase also in your lipase. So if it's in pancreas, I want you to remember, all right, this kind of cells, acinar or acinar cells. So in the stomach, if we have parietal cells, all right, in the pancreas, we have your acinar cells or acinar cells. And this causes, all right, or what happens here, there will be injury with our cells. So if our acinar cells are injured, all right, there will be, okay, retention of digestive enzymes in the pancreas and decreased digestive enzymes in the small intestine. I want you to remember that this digestive enzyme must go to our small intestine, okay, for absorption. All right, specifically for nutrient absorption and for digestion. However, in your pancreatitis, please take note, all right, that there will be minimal digestive enzymes happening in your small intestine or no digestive enzymes going to your small intestine. It will retain in the pancreas. Again, digestive enzymes will retain in the pancreas. And what's the danger here? The word digestive enzymes. These are enzymes that digest. So if there's increased digestive enzymes and be stocked in your pancreas, what will happen or what will it digest? What organ will it digest? Since these are digestive enzymes, it will digest or it will eat what? The pancreas itself. Good job. All right. So that's what we call autodigestion. It will eat its own organ. Okay. And that's very painful. Where is the pain located? Left upper quadrant pain and sometimes mid-epigastric pain. So if it's eating its own organ, if it's having its own autodigestion, expect that there's also bleeding. Okay? And we call that bleeding with your in relation to your pancreatitis would be your Collins sign and your Gray Turner sign. I'll show you a picture first. So here, okay, is an example of bleeding for your pancreatitis. In your umbilical area, we call this one what sign? Okay, just remember Edward Cullen. Okay, we call this sign Collins sign. Okay, this is a kind of bleeding, okay, in the umbilical area or sa abdomen area natin. As compared to your another kind of bleeding, if it's present in the flank area or on the side, just remember 50 Shades of Grey, okay, a movie, all right, so that you would know that this is called Gray Turner sign. Gray Turner sign, all right? So these two signs are bleeding found in your pancreatitis due to autodigestion. Again, if it's in the umbilical area, it's what you call your Collins sign. If it's in the flank, it's what you call your Gray Turner sign. All right? So that's for your bleeding. Now, all right, that happens in the increased digestive enzymes in your pancreas. Now, there's also an effect if there's a decreased digestive enzymes in our small intestine. Since our small intestine are needed for absorption, okay, of what we eat, okay, specifically the nutrient absorption and for digestion as well, there will be less absorption or might as well malabsorption of our carbs, our fats, and our proteins. And what we can see, okay, in the labs, all right, or in the client would be what we call our steatorrhea. Have you heard about this term, steatorrhea? What is steatorrhea? What is this? That's presence of fats in the stools because fats are malabsorbed. So you can see fatty stool, all right? Hence, we call it one steatorrhea. Now, I want you to remember, all right, when the pancreas are damaged, when the pancreas has inflammation or damage, fatty acids are generated, excuse me, fatty acids are generated by your pancreas, okay, or by your pancreatic lipase, all right? So there will be presence of fatty acids that will bind, okay, or that will bind with your calcium salts. Please take note of this one, okay? Fatty acids, okay, that are generated by your pancreatic lipase, all right, binds with calcium because fats are not absorbed here, all right? Hence, we have your steatorrhea. So once it binds with your calcium, okay, it will get the calcium from your blood. Hence, we could also have, or we could also experience hypocalcemia. Please take note of this one, hypocalcemia. So I will add another signs, okay? Another two signs, okay? In relation to your hypocalcemia happening in your pancreatitis, can you remember what are the two signs of hypocalcemia that are present, okay? Especially when we have pancreatitis. One starts with the letter C. That is your Vostek sign. Okay. Do you remember your Vostek sign? What is this one? What is this sign? This is tapping of what? Vostek sign is tapping of your ipsilateral facial muscle or your cheeks. Okay, so there's twitching. That's your Vostek sign, a sign of hypocalcemia. Another sign, I'm not sure about the spelling, all right, but this is what they call your Trosso sign. Yan. All right. So that's your Trousseau sign. Another sign of your hypocalcemia. What do we mean by Trousseau sign, or how do we check? Yeah. So if there's inflation of your BP cuff, we could experience our carpopedal spasm. All right. So two signs in addition to your pancreatitis, aside from your Collins sign and Gray Turner sign as a form of bleeding. Again, we could experience hypocalcemia due to binding of fatty acids with calcium. Since fats are not absorbed, we could experience our Vostek and our Trousseau sign, right? Signs of hypocalcemia. And if it's hypocalcemia, do we need to watch out for laryngospasm? Yes, okay. So is airway a priority here? Yes, okay. How about shock? Why do we have shock, or why do we need to prioritize shock? Shock from what? Shock from the bleeding, all right, due to autodigestion. And of course, fluid and electrolyte imbalance. So we give your calcium gluconate as a management. For bleeding, we give or we hydrate the client. We give your isotonic solution via IV. What else? All right, for your pancreatin or your pancreatitis, these are alternative for our digestive enzymes to digest our carbs, protein, and lipids. And of course, worst case scenario, since we wouldn't want to increase more or to add more digestive enzymes, at first we need to have bowel rest. All right, bowel rest or TPN. Or else there will be chances of increase or production of more digestive enzymes. Hence, there will be worsening of signs and symptoms for your pancreatitis. All right, so that would be for your pancreatitis. Again, please take note of this one. Collins sign in the umbilical area, bleeding, and Gray Turner sign in the flank area. Another two signs would be your Vostek and your Trousseau sign because of hypocalcemia. So that would be for your pancreatitis. Pancreatitis. Priority here, airway and bleeding. All right, so let's now move on with your gallbladder. Gallbladder, what is the function of your gallbladder again? What's the function of your gallbladder? That is to what? Storage of bile. Bile is used for what? Again, bile is used to emulsify our fats or fat emulsification. All right, so our gallbladder works together with your liver, all right, for that bile transport, all right, through your common bile duct. All right, and of course, to serve its function to emulsify the fats or to break down the fats. Now, the problem with your gallbladder is we could have your cholelithiasis and your cholecystitis. If it's chole, just remember chole, we are referring to the gallbladder itself. When we say lith or lithiasis, there's presence of what? When we say lith, there's presence of gallstones, all right? Gallstones. Now, can gallstone cause obstruction? Yes, all right, which will lead to inflammation called cholecystitis. So, cholecystitis, okay, the predisposing factor for that inflammation would be the presence of your gallstones. So, from gallstones, we want to remove that in order to prevent further inflammation or to prevent happening of cholecystitis. So, what are the risk factors, ma'am? Or why do we have gallstones? What makes our gallstones? We have 5-letter F. Can you give me examples for the risk factors, or who are most at risk for having gallstones? So female, very good. Females more than males. Fat people, all right? Because of what? Because of their diet, of course. So they have high lipids. 40 and above patients are more at risk. Fertile, why fertile? Because of increase estrogen and cholesterol levels, all right? And fair-skinned, ayan, mga fair-skinned also are risk factor. So just remember this 5-letter F, female, fat, and fertile, and 40 and fair. All right, female, fat, 40, fertile, and fair. Those are 5-letter Fs that are risk factors for your gallstones and inflammation of your gallbladder. Now, just a quick recap again, since cholelithiasis, all right, has presence of what again? There's presence of gallstones, all right? So what will happen? Can that stone cause obstruction? Yes, okay. So if there's obstruction of your bile, all right, coming from your liver, all right, obstruction in the passageway, all right, in the common bile duct, all right, so there will be chances of the same signs and symptoms like your hepatitis or icteric stage, but here the cause is obstruction, all right. So the bilirubin or the cholesterol can form that stones that will block or that will obstruct the common bile duct. Hence, this causes most directly rise of your bilirubin in your bloodstream. All right. Again, also, there will be backflow of bile. All right. So if there's backflow of bile, there will be irritation in the gallbladder. So there will be complication called cholecystitis. So if it's stones pa lang, we need to remove that already. All right. And of course, you might feel some pain if it's already inflamed, all right, with your gallstones or your cholelithiasis. So again, due to obstruction in the common bile duct, all right, there will be bile obstruction and backflow of that bile. Backflow would cause irritation. Bile obstruction will cause blockage in the common bile duct, hence rise of your bilirubins. That's why you have your pruritus, jaundice, tea-colored urine, and clay-colored stool, which are also present in your cholelithiasis. For cholecystitis, again, predisposing factor for this one is the presence of stones, all right, which causes irritation and then inflammation. Now, inflamed gallbladder, take note, all right, if we have an inflamed gallbladder already, plus, we are naughty and we eat still fatty foods, all right, that would worsen the condition, all right, and that would give us our pain, all right, and some signs related to your cholecystitis, which are radiating pain, called your Bose sign and your Murphy's sign. I'll just show you first, all right. Bose sign are signs, is a sign of right shoulder pain, all right. Right shoulder pain is what we call your, just remember this one, your Bose sign, all right, due to increased intake of fatty foods, all right, so you would feel this kind of pain in your right scapular. So Bose sign. Another sign related to your cholecystitis is what we call your Murphy's sign. Murphy's sign. So what we will do, as seen in the picture, all right, we ask the nurse, all right, to us nurses, we ask the patient to inhale, all right, as we deeply palpate, all right, as we deeply palpate the area, all right, the patient would suddenly stop breathing because there will be presence of pain. All right, so that would be your Murphy's sign. All right, ask the patient to take in and hold a deep breath while palpating. All right, the right upper quadrant area, the patient will suddenly stop breathing and experience pain. That's your Murphy's sign. So again, going back, these are kind of pain or radiating pain in connection to your cholecystitis. So Bose sign and your Murphy's sign. The priority here, of course, is your pain. Because this is very painful, all right? For symptomatic patients, we give your Demerol. For asymptomatic patients, we give your Ursodiol. Ursodiol are used to help dissolve the stones, all right? But if there's already inflammation, we do our surgical management, and none other than, we call it your removal of the gallbladder, which is what we call your cholecystectomy. All right, that's a surgical management for your cholecystitis. Have you assisted doctors, all right, during cholecystectomy procedures? Yes, okay. So we have either your open cholecystectomy. We could also have your lap chole. Okay, by the use of your laparoscope. All right, so we have your lap chole and your open cholecystectomy. Both are used to remove the gallbladder. But question, which is most at risk for infection, open or your lap? Which is most common? Risk for infection, that would be, of course, your open. Okay, as compared to your lap chole. All right, and it would take a longer time to heal. All right. So after your cholecystectomy, of course, post-surgery, we have this what we call your T-tube drain. So we drain the bile, and normal drainage for that within 24 hours is roughly 300 to 500 cc or 300 to 500 ml per day, all right? After post-surgery for your cholecystectomy. But usually nowadays, doctors prefer more the laparoscopic treatment more than the open cholecystectomy due to increased risk for infection. All right, so but still these are both management in order to for your cholecystitis to subside. To remove the inflammation, we might as well remove the gallbladder, right? So that would be for your cholecystitis. Again, both sign, right shoulder pain, Murphy's sign, asking the patient to take in and hold deep breath while palpating the area. All right, there's the patient would suddenly stop breathing and there's presence of pain. Again, Murphy's sign. So let's now move on with your lower GI tract, our last part or last system, lower GI system. All right, so the remaining parts of your GI system would be your small intestine and your large intestine. So here we'll be talking about your jejunum and your ileum. Small intestine are used for what absorption? Small intestine, what does it do in our body? What is it used? This is used for nutrient absorption, all right? We also have vitamin B12 absorption site. Okay, vitamin B12 absorption site, which is found in your terminal ileum. I'm not saying vitamin B12 absorption or production of your intrinsic factor. All right, the one that produced that one is your stomach, but the absorption site is in your terminal ileum. All right, so it works together with your small intestine. Disorders concerning that one would be one type of your inflammatory bowel diseases, which is your regional enteritis or your Crohn's disease. Okay, so that would be for your small intestine. Large intestine, or what we call our colons, all right? Our colons, we have your ascending, we have your transverse, we also have your descending and your sigmoid. Now, question, what is the use of your colons? What is the large intestine's action in our body? What does it do in our body? We reabsorb what? Water, and after that, we form, the last part, we excrete the stool. All right, so water reabsorption and stool formation. Common disorders related to your large intestine would be another type of your inflammatory bowel disease, which is your ulcerative colitis. All right, and of course colon problems would be your diverticulosis and diverticulitis. I already included here your appendicitis, but this is not related to your colons. This is related to your appendix, so we will also discuss this one. All right, so let's now start off first with your IBD. All right, IBD is your inflammatory bowel diseases. There are two types. We have your Crohn's disease, or what we call your regional enteritis. Regional enteritis. All right. On the other hand, we have your ulcerative colitis. Ulcerative colitis. The common location affected with your Crohn's disease is what you call your small intestine and your large intestine. Again, two intestines are involved in your Crohn's, all right? As for your ulcerative colitis, from the word itself, inflammation of your colons, colitis. That's why only the large intestines are affected here, all right? With the lining affected for your Crohn's disease, since there's already affectation in your small and large, there will be presence of fistula. All right, fistula is a hollow organ connecting the layers of your small intestine. All right, but when your ulcerative colitis, it is the colons only, but there's presence of ulcer, hence the term ulcerative colitis. All right, so due to the inflammation, there will be ulceration in your large intestine or in your colons. So common site for your Crohn's would be the last part, which is your terminal ileum. Common site for your IBD, for your ulcerative colitis, would be your rectum, but also can happen in your ascending, transverse, descending, and sigmoid. All right. Now, question, between the two, which do you think has bleeding? If si Crohn's are just fistula, who do you think, and ulcer is the colitis, which between the two has bleeding? Your ulcerative colitis. And since it's the last part of your digestive system, all right, or your GI system, the kind of bleeding here is not melena, it's not black tarry, but rather bright red, which is what you call your hematochezia. All right. So aside from bleeding, question, can Crohn's have diarrhea? Yes or no? Do we have diarrhea in Crohn's? Yes. How about in colitis? Do we have diarrhea aside from bleeding? Both have diarrhea. Remember that. Both have diarrhea. Since our bowels are inflamed, all right, it will increase its peristalsis. It will disturb our bowels. So both can have diarrhea. However, in Crohn's disease, there's presence of steatorrhea. There's fatty stool. Why? Because we are in Crohn's disease, small intestines are affected. So there's no also absorption of fat. So there would be presence of diarrhea plus steatorrhea. But in your ulcerative colitis, there's no steatorrhea, but rather there is diarrhea with bleeding. All right, or rectal bleeding. That's the difference between your Crohn's and your colitis. Again, both have diarrhea. So how do we manage this one? Of course, we manage it by giving, since this is IBD, this is inflammatory, we give anti-inflammatory medications such as your corticosteroids and your sulfasalazine. We also can give anti-diarrheals, all right? And of course, we give your prophylaxis, all right? For to prevent bacterial infection due to your IBD. So or due to persistent diarrhea, we give your neomycin. So as a diet management, why is it that we decrease fiber, or we do not give high fiber diet, and we load the residue diet for the patient? Why? Why do we decrease the fiber and we provide low residue diet such as boiled egg and broiled meat? Because there's diarrhea. It would further worsen the diarrheal episodes, all right? Nuts, seeds, beans, kernels, and cash diet. Why is it not allowed? It would cause what? Okay, it would cause irritation. Okay, since we're having already inflammation in our small and in our large intestines, we wouldn't want to give such. All right, so as an addition, all right, we do not give atropine, especially for ulcerative colitis, because this will lead to toxic megacolon. I'll show you a picture. All right, yeah, and that is toxic megacolon. That would disturb the large intestine and would looks like we have larger size for your um, colons. All right, so both are prone to dehydration and colon cancer. So we manage that one by giving anti-inflammatory medications. All right. Now, addition to your large intestine or your colon diseases, we add our diverticular diseases. So we have your diverticulosis and we also have your diverticulitis. When we say diverticulosis, okay, of your diverticulum or your diverticula, we have presence of what here? We have presence of what? Affecting part here is only the colons or your large intestine. When we say diverticulosis, there's presence of outpouching or herniation. Outpouching or herniation. When it comes to diverticulitis, okay, this is already inflammation due to diverticulosis. All right, inflammation due to diverticulosis. So this is not versus, this is actually a stage. All right, so diverticulosis first, and then if there's inflammation, it will lead to diverticulitis. But for the diverticulosis, can I ask, what do you think are the reasons for that outpouching or herniation of your intestinal mucosa? What do you think are the reasons? Why are there outpouching? Or what are the causes? Pressure, of course, due to what? Due to increased pressure due to what? Can constipation be a reason or a risk factor? Yes. Okay. So aside from constipation, usually we do not actually feel diverticulosis. So as a diagnosis for that, we do the following. We do colonoscopy, barium enema, and CT scan. So this is usually painless, all right, or asymptomatic. However, all right, for the risk factors, all right, since we have chronic constipation here, all right, we do not eat lots of high fiber diet, so less vegetables, aging as well due to weakening of our colons, seeds, all right, and of course, high intake of red meats every day, some jupsal every day, steak every day. Yeah, that's what we act. And then we do not increase our fluids and fiber. All right, that's for your diverticulosis. Do you eat vegetables? Yeah, so this is actually seen for um or common male older male, because they experience constipation, and of course they eat, or their diet is not high fiber, so they usually eat lots of red meats and so on. So from the risk factors, you would already know how to manage. All right, can you give me management if you know already the risk factors for diverticulosis? What must you tell the patient? To prevent diverticulitis, we increase what? What do we need to increase? Okay, there's a difference, right? There's a difference. In your diverticulosis, we increase the fiber. We increase the fiber and the fluids. Now, if it will lead to diverticulitis, meaning there's already inflammation, okay, our colons have been irritated and inflamed already, there will be disruption in the peristalsis. So there will be, okay, aside from infection, all right, there will be presence of diarrhea. So diverticulosis cause is constipation, all right? Once the diverticulum is already inflamed, all right, expect that patients might have fever and increased white blood cell count due to inflammation. And there's also diarrhea, all right? So what will be the diet for diverticulitis? Would we increase the fiber here? Yes or no? Diverticulitis. Do we increase the fiber here? How about diverticulosis? And so for diverticulitis, bowel rest. All right, we do bowel rest here because of persistent abdominal cramping and diarrhea. All right, so no fiber, no high residue diet. Alright? So, of course, we want to prevent peritonitis. Okay? Best management for this one would be colostomy. Alright? Or presence of your stoma. And to prevent infection for your colostomy, we give your neomycin as well here in your diverticulitis. So the difference between that one would be the diet and of course the stages, all right? So if you want to prevent diverticulitis, we need to manage diverticulosis, all right? So that would be for your diverticular diseases. Last topic would be your appendicitis. Do you know someone who experienced, I changed the management, sir, in your handouts. Please move the no milk and ano yung isa? Ambulation to your diverticulitis because of the diarrhea. Just change it, all right? So no milk and ambulation for your diverticulitis. Ibayin nyo na lang. Alright, so last topic would be your appendicitis. Does this sound familiar to you, or do you know someone who have experienced appendicitis? Hello? Okay, what is appendicitis? Appendicitis is what? Inflammation of your what? Appendicitis is inflammation of your appendix due to what? What might cause your appendicitis? What might cause appendicitis? Or what causes appendicitis? Before it turns into an infection, what causes your appendicitis? Can you help me? It's already there in the screen. Okay, trapped fecalith. What else? Aside from trapped fecalith, what could be possible causes of appendicitis or trapped materials in your appendix? Can seeds be trapped there? Yes, okay. So dropped fecalith or dropped seeds, could it harbor bacteria? Or when it's stuck there, could it cause bacterial infection? Yes, that's why you could have presence of fever, okay, when you have appendicitis, increase in the WBC count, and of course, more and more inflammation that would happen in your appendicitis. Now, is appendicitis painful? Is it painful? Very painful. Is it continuous? Where will we assess the kind of pain in appendicitis? Where is it located? In your right lower quadrant, or what we call our McBurney's point. All right. So as you can see in the client with diagnosed with appendicitis, there's rebound tenderness, there's right lower quadrant pain that is continuous, and you could see patients guarding his or her abdomen because it's really, really painful. All right. Due to infection and inflammation. Question, if there's sudden relief of pain, will you be happy? No, why? If there's sudden relief of pain, what do we mean by that? What might happen? There's rupture, all right? And rupture could lead to what? Complication. Sepsis and peritonitis. All right? So in order to prevent that one, ma'am, I'm having appendicitis and I'm having right lower quadrant pain. All right? As a nurse, will you give pain medications or pain reliever? Yes or no? Why? It's very painful. Why don't you need to give pain reliever? What's the reason behind it? It will mask the pain, all right? Because we want to check if there's rupture, all right? If there's no more pain, all right? So, what then will be our management if we don't give pain reliever? What's the emergency management for appendicitis? What surgery? Appendectomy. Good job. All right. So, to elicit signs of appendicitis, okay, very important is we do not touch. All right. We do not touch the painful part, which is your right lower quadrant. Now, we have what we call your psoas sign and your Rovsing signs, all right? Psoas sign, all right, as you can see in the picture, this is elicited by having the patient lie on his or her left side, all right? And then the right thigh is flexed, all right? Right thigh is flexed, or it could be backward, all right? So once the right thigh is flexed, upon extension, after flexion, there's presence of pain. Again, psoas sign, psoas starts with letter P, psoas sign, right thigh is flexed upon extension, there's presence of pain. Okay, that is pain for your appendicitis. Another sign would be what you call your Rovsing sign. When you say Rovsing sign, we palpate not the right lower quadrant. We never palpate that. All right? We palpate the left lower quadrant. We palpate the left lower quadrant, but the pain will be felt on the right lower quadrant. Again, we palpate the left lower quadrant. Now, due to palpation, there's pressure happening, so the pain will be felt in the right lower quadrant. What sign is that? That is your Rovsing sign. So do not forget, in appendicitis, we have two common signs. We have your psoas and your Rovsing sign. Now, for your management for your appendicitis, there's no other management but your emergency appendectomy. All right? So during that one, of course, we do the following pre-operative interventions, and we do not give hot compress. All right? That's a no-no for the client. Do we give laxative and enemas? Of course, no. Okay, it will trigger rupture as well, right? So that would be for the management, would be for your appendicitis, your appendectomy. Do you have this one in your notes? All right. So again, to summarize, no avoid or no laxative, no enema, no heat application, and so on. And of course, no pain relievers, because pain relievers will mask the pain, all right? So if there's rupture, okay, of the Dix, if there's rupture already, it might lead to peritonitis, which is already a complication. All right? So check if there's sudden relief of pain. All right? So this is also an emergency complication for your appendicitis. Is this clear? Is this clear? Wala nang sumasagot. Okay, so before we take our post test, let's just have a quick recap or a quick review of our gastro. All right. My first question is, do you love gastro? Sagot naman kayo. Dapat, of course, should be. Okay, let me know if you really love gastro. Okay, tell me if it's gastric or duodenal. All right, without looking in your notes, without looking. Pain during meals. This is just a review. Vomiting. No vomiting. Okay, weight loss. Gastric. Pain 2 to 4 hours after meals. Duodenal. Hematemesis. Gastric. Weight gain. Avoid cash diet. Ano yung B? Both. Good job. Crohn's or colitis, regional enteritis. Another term for? Do I only have one student? Yan, Crohn's. Okay, what about ulceration? There's ulcers, there's wound. What is this? Colitis. Terminal ileum is affected. Crohn's because it's a small intestine. What about affects colon only? Ang daya nung iba, letter C lang. Pares kaya letter C to. Colitis. Okay. Rectal bleeding. Colitis. 5 to 6 watery stools per day. 10 to 20 watery stools per day. Colitis. Steatorrhea. Okay. Hematochezia. Okay, what if it's just diarrhea? Good job. Very good. Galing nyo. Antacids, best time to take. After meals. Stidins. With meals. Prazoles. Before sucralfate. Before meal. Cytotec. With meals. Good job. All right. Signs. Okay. Mabilis na answer. Murphy's sign. Quick answer. Come on. Without looking at your notes. Murphy's. Ulit. Recap of lecture. Joke. Murphy's sign. Murphy's. Wrong answer. This is your correct. This is your gallbladder. Cholecystitis. Okay. Gray Turner. Quick answer. Gray Turner. Pancreatitis. SOAS. SOAS sign. Appendicitis. Bose sign. Cholecystitis. Ibang SOAS sa Bose, it's different. Alright? Bose sign and Murphy's sign, cholecystitis. Collen sign. Pancreatitis. Rovsing sign. Rovsing. Appendicitis. Ayoko nagkakamali. Gusto ko perfect tayo. Murphy's sign. Murphy's. Murphy's. Cole. Gray Turner. Pancreatitis. Psoas. Appendicitis. Good job. Bose sign. Cholecystitis. Colon sign. Pancreatitis. Rovsing sign. Appendicitis. Okay, thank you. Now I'll give you time to, do we need break or post-test right away? So we could dismiss early. Ngayon na, 20 items lang naman. Are we ready for post-test? And then we will rationalize after. This is just 20 items. Okay, all right. So let's start with your post-test. For those, as we check the pacing, let's just follow the screen time. All right. So this is a minute per number. Rationalize after the last item. So let's start. Are you guys done? Can we review our answers?
Ma'am, not yet pa po.
Okay. 2 more minutes. Sige. Okay, so shall we start to discuss our answers? All right. So first question, all right. Everyone done na ba? Tapos na ba lahat? Are we good? Everyone? Please let me know if you're not yet done. Okay na ba? Yes, all right. So let's start off with the first question. A histamine 2 receptor antagonist is prescribed for a client with duodenal ulcer. The nurse is correct in identifying H2 receptors antagonists if she includes which of the following medication. So we are going to look here. SATA, H2 receptor antagonist or blockers. What are your answers? All right, so our answer would be our Tidins medications, H2 receptor blockers. What about 5 and 6? What are these? What are 5 and 6? These are examples of our proton pump inhibitors. Good job. Did you get this? Good job. Number 2, which lifestyle and nutritional changes can help clients minimize and manage the signs and symptoms of GERD? GERD, all right, SATA. In GERD, do we need to do number 1, restrict coffee in the diet? Or do we encourage? Encourage, discourage? Okay, so since this is part of the cash diet, we do not give caffeinated drinks. Number 2, choose foods that are less fatty. Is this correct? Yes or no? High fat food can also trigger our GERD. Number 3, eat 3 meals a day with minimal or no snacking. What must be done if it's reflux? 3 large meals or what? Small, frequent feeding. What about number 4? Encourage hot, spicy, ipudo, hot, spicy, ichiran, hot, spicy, ramenagi. No, hot and spicy food are also triggers, all right? What about number 5? Sips of water with meals. Are these important together with your small, frequent feeding? Good job. To prevent, of course, your HCl backflow. Number 3, lactulose has been prescribed for a client with advanced liver disease. Which of the following assessments would the nurse use to elevate effectiveness of our lactulose in our advanced liver disease, such as our liver cirrhosis? How would we know if lactulose is effective? If it's what? If there's an improvement in your level of consciousness. So number 3 is your answer. Number 4, cimetidine or Tagamet is administered to client with GERD. Which finding should the nurse conclude that the client is experiencing adverse effects of GERD? What have we discussed? All right. Side effects. What about the side effects of our tidins? What are our side effects? Your Vanda, all right? Vomiting, anorexia, nausea, diarrhea, and abdominal cramps. What are the side effects of PPI? Vanda as well. What about Amphogel, aluminum hydroxide? What about milk of magnesia or magnesium hydroxide, diarrhea? What do you call that combination medication of your Amphogel and magnesium hydroxide? What do you call that? Maalox. Maalox is under what category of upper GI meds? Maalox is under what category? Among the AHPSC. What is Maalox? Antacid. Good job. The patient is receiving cimetidine and also Amphogel. The question here is, which of the following instructions, if given by the nurse, is best SATA? So we're going to check, we're going to answer when's the best time to take cimetidine, when's the best time to take Amphogel. With your cimetidine, when's the best time? 1 hour before meals, with meals, or an hour after meals? Answer between 1, 2, or 3. Number 2. What about your aluminum hydroxide or your Amphogels? Is it number 4, 1 hour before meals, or number 5, 1 hour after meals? So Amphogel is your antacids. These are taken after meals. So the answer here are 2 and 5. Did you get this? Yes. All right. Number 6. Let's answer this one. The question here is, we have to identify the illustration which between the 4 undergo Billroth 1. Number 1. What is number 1? What is this first? Number 1. Stomach is joined to the jejunum. This is Billroth 2. Good job. What about number 2? Stomach is joined to the duodenum. Is this your answer? Yes. Actually, it also is vagotomy because we resected here the vagus nerve. What about number 3? What is this surgical procedure? What is this number 3? This is what? Surgical management. This is actually for GERD and hiatal hernia. What is this number 3? It's a gastric wrap around. What is this? What's number 3? That is your Nissen fundoplication. Good job. What about your number 4? What's number 4? What is this? What happened here? What surgery is this? Number 4, there's no stomach already. What is this? This is your total gastrectomy. Good job. Next, number 7, the nurse is discussing pain from cholecystitis with a client. Which statement made by the client most accurately describes this typical pain? So with your cholecystitis, the patient experienced pain. What happened? Why did the patient experience this pain? What's your answer? Is it because number 1, below my sternum? Number 2, eating food makes the pain better? Number 3, the pain gets worse after I eat fatty foods? Or because number 4, constipation? What's the answer? When we talk about cholecystitis, what's the cause or what triggers more the pain? Of course, number 3, high-fat foods or eating fatty foods. And this is one of the risk factor among your 5F, all right? Fatty food diet. Number 8, the question here is, which of the following lab values will the nurse interpret as confirming client's diagnosis for pancreatitis? Pancreatitis, what are you expecting? Elevated what? Elevated what? Amylase only or digestive enzymes? Answer here is number 2. You're correct. What makes number 1 wrong? It should be increase. What about your number 3? What makes it wrong? Do we have hyper or hypo? Hypocalcemia here, right? Number 9, the patient is diagnosed with appendicitis. Which of the following conditions or signs can be a manifestation? SATA. Appendicitis, what are the signs for your appendicitis? We've already reviewed this one. The answer is your psoas sign and your Rovsing sign. Again, psoas sign is right thigh flexion upon extension. There's pain. Rovsing sign, palpation of your left lower quadrant. The pain will be felt in your right lower quadrant. That's your Rovsing sign under appendicitis. Number 10, a client undergoes barium swallow fluoroscopy that confirms GERD. Based on this diagnosis, the client instructed to take which action? SATA. When you have a GERD, would you do number 1? Follow a high-fat, low-fiber diet. What should it be? It should be low fat. Number 2, is this correct? Avoid caffeine in carbonated beverages. Yes, it's one of the trigger factors. Number 3, what makes this wrong? Sleep with the head of the bed flat. Is this correct? It should be elevated or high upright position or up to semi-Fowler's. Number 4, is this correct? Stop smoking. Correct. Number 5, take antacids after meals. Also correct. Number 6, limit alcohol consumption to 1 drink per day only, ma'am. Because I love alcohol. 1 drink only. Avoid or limit. If you have a GERD, even if you say limit, it's still wrong. So avoid is the best answer. 2, 4, and 5. Did you get this? Yes. All right. Number 11, signs for cholecystitis. Which of the following manifestation is related to cholecystitis? What's your answer? SATA. Cholecystitis, we have your Bose sign, right shoulder pain or right scapular pain, and we also have your Murphy's sign, 2 and 5. Number 12, which of the following foods are contraindicated with GERD? SATA. Number 1, coffee, yes or no? Beer? Milk chocolate? Crackers? Can we eat crackers with GERD? How about jalapenos? What is jalapeno? This is spicy or chili, the green chili, all right? So all except number 4. 4 is okay with GERD, but number 1, 2, and 3, 1, 2, 3, and 5 are part of your cash diet that must be avoided. Number 13, sucralfate. The question here is, why is this medication beneficial effect for the client? What's your answer? What's the mechanism of action for your sucralfate? It will not reduce GI spasm. It will not relieve nausea and vomiting. It's not an anticholinergic, but rather it's a cytoprotective agent that protects the stomach lining or the mucosal lining, all right, from the acidity of your stomach. It coats the ulcer, number 2. Good job. Number 14, pre-icteric stage. This is actually hepatitis. But same options, all right? Pre-icteric, what will the patient feel if there's liver inflammation? Number 3. What about your 4? When does this happen? Number 4. Pre-icteric, icteric, or post-icteric? That would be your icteric stage. Good job. Number 15, a nurse is caring for a client with acute pancreatitis with hemorrhage. Which of the following manifestations are expected? Acute pancreatitis. Number 1, is this possible? Yes. How about hypocalcemia? What about Collins sign and Turner sign? Due to bleeding. All right. So the answers are 1, 2, 3, and 4, except your number 5. All right. Under hypocalcemia, what are the 2 common signs in relation to your pancreatitis? We have your Vostek and your Rousseau. Again, this is due to lipolysis, binding of your fatty acids with your calcium soaps, triggering your hypocalcemia. Collins sign and Turner sign are signs of what? Signs of ano tong 3 and what is 3 and 4? Signs of pancreatitis because of bleeding due to autodigestion. Number 16, select all that apply. The patient is diagnosed with gastric ulcer. 1, pain during meals, or 2, pain 2 hours after meals. What about vomiting? Vomiting or no vomiting? Weight loss or weight gain? All right, so poor man's ulcer, the answers are 1, 3, and 5. Number 17, it's just the same. However, the question here is duodenal ulcer. All right, pain during or pain after? Vomiting or no vomiting? Weight loss or weight gain? Weight gain happens because pain is felt after meals. The client vomits or overeat to relieve the pain. What is the bleeding in your duodenal ulcer? Bleeding. What's the bleeding in your duodenal ulcer? What kind of bleeding? Huh? Is it hematochezia? Duodenal ulcer is upper GI bleeding. So it's black tarry stool, it's melena. Good job. How about your gastric ulcer? What kind of bleeding is present in gastric ulcer? That would be hematemesis. All right. Hematochezia is bright red bleeding. Saan to present? What disorder is hematochezia present? It's not ulcerations. It's in your colitis. Ulcerative colitis. It's not in your PUD. Number 18, a client who has right upper quadrant pain for several months now experiences clay-colored stools and visits the local clinic. Based on the reported history and elevated liver enzymes, a needle biopsy of the liver is scheduled. So liver biopsy, number one, what makes this wrong? The procedure is painless because general anesthesia is used. It should be? It should be what? Local anesthesia. What about number two? Disfiguring scars are minimal because a small incision is made. Small only? No. And of course, scars are not minimal because liver is a major organ. All right? And also highly vascular. Number three, lying on the right side after the procedure is required because it will decrease the risk of hemorrhage. Is this correct? Yes, again, liver is highly vascular. Number four, light meal should be eaten prior to the procedure. Is this correct? Will you do this? No, dapat should be what? Should be NPO, no meal prior to liver biopsy. Number 19, a nurse is assessing a client newly diagnosed with Crohn's disease. Which findings is associated with Crohn's disease? Crohn's disease is under what disease? Crohn's disease is under what disorder? Inflammatory bowel disorders. So what happens in Crohn's disease? Is it constipation or diarrhea? Is it constipation or diarrhea? Okay. So if you're having diarrhea, is number one correct? Would you expect weight gain or weight loss? Of course. And of course, it's not constipation, it's diarrhea. Between 3 and 4, Crohn's disease. Fatty stool or bleeding? Number 3. What disorder is number 4? Instead of Crohn's, this is more present in ulcerative colitis. Good job. And the last question is, what is this sign as a whole? One of the hallmark signs for your pancreatitis. What is this sign? This is what you call your Collins sign. All right. Some student answered Edward Cullen. If you answered Edward, that's wrong ha. Only Collins. Wrong kayo dyan. Pag may nilagay kayong Edward, walang ganun sa sa NCLEX. So did you get this, guys? Number 20. Yes. Again, I just put the picture of Edward Cullen for you to remember, all right? But this is only called Collins sign, not Edward's sign. All right, so that ends our gastro. So for the remaining time, we can answer more practice questions in regards to your GI system. I hope you learned a lot today, and please study your GI. Thank you very much and have a great night. Good